variety of suspicious areas, which is especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI is supporting better visibility of potential resulting in image details at a level that typically only very experienced endoscopists have learned to see. TXI aims to contribute to lower miss rates for inflammation and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of TXI is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce TXI as the new white light. Edop provides a continuously sharp image at any point in the endoscopic workflow. Edop stands for Extended Depth of Field. The incoming beam of light is divided by the beam splitter and reflected via two mirrors to the sensor. This technology projects two images with identical content that, however, exhibit different focal lengths and combines those images into one image in total focus. Edop supports the detection of lesions through improved visibility, thanks to a broad focus range and less blurring. Edop allows for a much closer distance to the object in normal mode compared to previous dual-focus endoscopes. Therefore, Edop was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. Edop is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, it allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. Observations, NBI enhances the visibility of superficial vessels.
Good morning, Dr. Sifrin.
NBI stands for narrow band imaging. In contrast to the previous series, XVII, NBI uses LED illumination.
I cannot hear you well. I'm sorry, but I cannot hear you well.
Yeah, okay. Now, because they have some commercials prior to the starting of the workshop, so here we will start in a 9 o'clock, and I will make some short introduction of your lecture, and after that you will have your free time, and I think that you will get to the Cambridge to your new webinar at 10 o'clock. Do you hear me now?
Can I ask you how to share my presentation in this program? I don't know how to do that.
Yeah, Mr. Bonic Tomislav will help you immediately, and you will have a connection on your desktop, and immediately I will call him. I think that he was doing that. Tomislav, me čuješ?
Tomislav je na telefonu.
Aha, ako možete pomoći.
Što nisam čuo?
Nisi trebali da ja uspio da je ovo još priča sa Štrinom.
Možete ponoviti, evo, tu pričam, duplo mi pričam.
Odlučiti da stavi, da se dođe do desktopa, da stavi svoje predavanje.
Aha, znači on bi htio podići, dobro, ok, znači ima prezentaciju vjerojatno nešto.
Da, on ima prezentaciju, on je prvi naš lektor. On i profesor.
I think that I found it. I will try now.
Yes, you can try, you can share your screen. You can start a presentation and then you can share your screen. When it's layout, you will see where is share your screen. Yes.
Well, at this moment, I have. Can you see my screen now?
Yes. Yeah,
we clearly see.
Yes, this is of your presentation. Yes.
Can you see it now?
Yes, it's on the beginning. Okay.
Nice, that's great.
So I will stop sharing now.
I present here.
Okay.
Okay.
Mogu siis uključiti video?
Hi, Edop, how are you?
Very well. And, that's a new situation, so probably we'll be happy to
now we'll go
in a better time for Zagreb as well.
Now we'll go commercials, and then after commercial, you are Dr. Shifrin.
Will you let me know when to start?
Yes. Okay. Okay.
To enhance the visibility of suspicious areas, which is especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI is supporting better visibility of potential lesions, resulting in image details at a level that typically only very experienced endoscopists have learned to see. TXI aims to contribute to lower miss rates for inflammation and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of TXI is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce TXI as the new white light. Edop provides a continuously sharp image at any point in the endoscopic workflow. Edop stands for Extended Depth of Field. The incoming beam of light is divided by the beam splitter and reflected via two mirrors to the sensor. This technology projects two images with identical content that, however, exhibit different focal lengths and combines those images into one image in total focus. Edop supports the detection of lesions through improved visibility, thanks to a broad focus range and less blurring. Edop allows for a much closer distance to the object in normal mode compared to previous dual-focus endoscopes. Therefore, Edop was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. Edop is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, it allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. operations, NBI enhances the visibility of superficial vessels. NBI stands for narrow band imaging. In contrast to the previous series, EVIS X1, NBI uses LED illumination. Blue and green light penetrate only the superficial layers of the tissue. If a superficial blood vessel is present, blue and green light are both strongly absorbed. The vessel appears darker and is therefore more visible. If the deeper penetrating green light hits a vessel that is out of the reach of the blue light, only the green light is strongly absorbed. The deeper vessel appears in cyan, in contrast to the superficial vessel. NBI is the most validated and society-endorsed imaging modality for optical assessment of lesions. It supports high diagnostic accuracy and high confidence in diagnostic decisions.
Tomislav, ja sam ušla,
And
ja
it has
sebe vidim.
internationally validated
Jel
classification
ti vidiš me?
in place. Designed to enhance the visibility of deep vessels and bleeding points during endoscopic treatment. RDI stands for red dichromatic imaging. RDI uses an additional amber LED. Red light penetrates deeper into the tissue compared to green light. If a deep blood vessel is present, amber light is strongly absorbed. The vessel appears darker and is therefore more visible. If the amber light hits a bleeding point at which the blood concentration is very
Dragane, Bog.
Bog.
I Tomislav, isključite ostalima mikrofone, dakle, krećemo sa uvodom, ide onda profesor Sifrin. Mogu Tomislave početi ja.
Može.
Good morning, everybody. It's my great pleasure to open this 17th jugular workshop, Algorithms in Gastrointestinal Endoscopy and Endoscopic Ultrasound, which will be held despite the demanding COVID-19 related epidemiological situation in the world. Workshop is organized by the Croatian Society for Gastroenterology and Association of Nurses and Technicians in Gastroenterology of Croatia, and from the GI Endoscopy Unit, Department of Hepatology and Gastroenterology, University Hospital Center Zagreb, and the Croatian Institute of Emergency Medicine Telemedicine section, and also with a big help of Faculty of Veterinary School of Veterinarian from the University Hospital in Zagreb. The event is endorsed by Ministry of Health of Croatia and also with ESGE and SGINA as well. The workshop is tailored according to the epidemiological doctrine, and the first part of the workshop covers online working in operation rooms, and while the second part is dedicated for the training for the young endoscopists on the ex vivo porcine models and the live porcine models, and also according to the epidemiological doctrine in small groups up to 5. So I think that we can start our sessions, and it's my great honor to introduce the Professor Daniel Sifrim, and he has been appointed Professor of Gastrointestinal Physiology at Barts and the London School of Medicine and Dentistry at Queen Mary University of London. He was educated at the Buenos Aires University and in Leuven, Belgium as well, where he obtained his PhD degree and developed his academic and research career. His research focuses on the physiology and pathophysiology of the esophageal motility and gastroesophageal reflux disease. He has been devoted to development of new techniques to measure esophageal motility and gastroesophageal reflex. He serves as a reviewer for many gastroenterology journals and has authored and co-authored more than 100 original articles. He is very active in a group that brings out the official guidelines in this field. Many students, young scientists, and clinicians have that honor to learn from him. We are also very grateful, and as he kindly accepts our invitation to participate with the lecture update in diagnosis of GERD. So, Professor Sifrin, your time is coming.
Okay, thank you very much for the invitation to participate in this very interesting meeting. I'm very sorry that I cannot be in person in Zagreb, but it will happen. Sooner or later, I will visit you. I will now start my talk on an update in diagnosis of gastroesophageal reflux disease. Can you confirm that you see my screen?
Yes, we see your screen. Very well.
Okay. So these are my conflict of interest. When we have a patient with reflux symptoms, the first thing we need to know is if there are alarm signs, particularly weight loss, dysphagia, and epigastric mass. And if this is the case, we go straight to an upper GI endoscopy without any further delay. However, in the majority of cases, there is no alarm sign, and the patient is treated empirically with proton pump inhibitors, either once daily or sometimes directly twice daily. The passage from once daily to twice daily depends on the country and the department. But in general, in the US, they always start with a once daily. In Europe, it's very common to start with twice daily. In any case, now there is an alternative in some Asian countries with a pickup drug, which is another type of acid secretion suppression drug. It is called vonoprazan, and there are others also in the market in Japan. And this will come probably soon in Europe as an alternative to try to improve the response to PPIs twice daily. If this medical empirical treatment fails, what we have is the situation that we need to investigate what is going on. And this is what is going to be about my talk of today. Investigations are mainly based on endoscopy and reflux monitoring. Now, if the endoscopy shows esophagitis, there is no much to further investigate. The treatment of esophagitis is pretty well established. However, most of the times there are no erosions and the patient has what we call non-erosive symptoms. In that case, the patient will have a reflux monitoring study that can be either catheter-based or wireless. And this reflux monitoring study will determine whether the patient has a pathologic acid exposure or a physiologic acid exposure. If the patient has a pathological acid exposure, this is what we call now a non-erosive reflux disease. In contrast, if the patient has physiological acid exposure, there are two other possibilities. That the patient has a temporal association between physiological reflux episodes and his typical symptoms, and this is what we call now hypersensitive esophagus. And if the patient does not have an association between his typical symptom and reflux episodes, is what we call functional heartburn. This is what the Rome 4 criteria is establishing. There are three main phenotypes, as I said: true non-erosive reflux disease, reflux hypersensitivity, and functional heartburn. It is important to realize that the diagnosis of these phenotypes is based on endoscopy negative, reflux monitoring, but also on this reflux symptom association analysis. And this reflux symptom association analysis has some problems. One is that the SAP has a moderate association with treatment outcomes. Second is that depends very much on reporting of symptoms by the patient, and this is in general pretty poor. And finally, in patients with mild reflux, there is a high variability in the symptom association. Therefore, the phenotyping is very useful, but is somehow based on a weak tool. These are all the potential diagnostic modalities in gastroesophageal reflux from symptoms, endoscopy, biopsies, barium swallows, reflux monitoring in the different modalities, a new technique which is called mucosal impedance, some endoscopic techniques as NBI, and finally detection of salivary pepsin in saliva. I will go through most of them, not all, but most of them. Let's start with symptoms. Heartburn and regurgitation are the most reliable symptoms for diagnosis of GERD based only on history. The problem is that the sensitivity and specificity is pretty low. Many patients with dyspepsia might have heartburn, and the disease is not reflux disease, but is dyspepsia or an overlap syndrome. There are questionnaires that are designed for improvement of the symptom-related diagnosis. This is just one of the questionnaires, the GERD-Q, and that divides the situation in patients with a high probability of GERD. In those patients, they suggest that there is no need for further tests and just go to treatment. And there are patients with intermediate probability of GERD, and there you need to decide whether you just treat or study. And there are patients with low probability of GERD, where you need to perform tests to confirm or reject the diagnosis. A new thing that I really I'm very excited with and strongly suggest you to use is a questionnaire for esophageal hypervigilance, an anxiety scale. This is a questionnaire published in 2018 by the Chicago group, and it is very useful to detect patients with hypervigilance, which is a very important co-founder factor in symptoms perception. These are patients that either have reflux hypersensitivity or functional heartburn with high level of hypervigilance, and the treatment of hypervigilance is not easy and requires cognitive behavioral therapy. What about endoscopy? Endoscopy has an excellent specificity. You do the endoscopy, and if you find erosions, the diagnosis is done, esophagitis, strictures or Barrett's. The problem is that the majority of patients with reflux symptoms do not have esophagitis, EOE, strictures, or Barrett's. So the endoscopy per se has very high specificity and very low sensitivity. And one important thing to consider is that there are several reasons why there may be no endoscopic evidence of GERD. One is that the patient indeed has true NERD. It is a real non-erosive reflux disease. But even very common is the fact that the patient had a recent use of PPIs that might have healed the damage of the esophagus, and when you do the endoscopy, it looks like NERD. But the patient actually had reflux esophagitis a couple of weeks ago. And the other issue is that patients may have functional disorders that are responsible for the symptoms, and they are non-GERD at all. They just have dyspepsia or IBS. What about manometry? Manometry is important in the diagnosis of reflux indirectly. You don't do diagnosis of reflux by manometry, but you need to check several things. One thing is that some patients have achalasia. This is a type 2 achalasia pattern, and some patients with achalasia present with regurgitation, and even some of them with heartburn. And it's not very rare. It happens in our unit, and some patients have reflux symptoms in the context of achalasia. Another possibility is that the patient has regurgitation, and when we look at the manometric combined impedance study, the patient had a pattern of rumination. And this is something easy to diagnose when you perform a manometry with a test meal and a postprandial evaluation. This is a typical pattern of rumination, straining with liquid coming up into the esophagus. Another use of manometry in reflux disease is the detection of esophageal body hypomotility. This is a patient with ineffective esophageal motility, which can be involved in reflux disease. Of course, you can make a good diagnosis of a hiatus hernia. In this case, this is a sphincter, this is the diaphragm, and all this is the hernia. So you can make a very clean and accurate diagnosis of the length of the hiatus hernia with your manometry. You can also identify the type of hernia based on the configuration of the relationship between the sphincter and the diaphragmatic contractility. And finally, manometry is very useful in reflux disease to check the possibility of disruption of an anti-reflux surgery when the patient persists symptomatic with reflux symptoms after anti-reflux surgery or endoscopic anti-reflux procedures. This manometric pattern is showing an intrathoracic fundoplication, whereas this one shows a disrupted intrathoracic fundoplication. So we can use manometry before the diagnosis to know the motility of the patient, to perhaps modify the strategy for anti-reflux surgery if the patient has severe hypomotility. Of course, exclude surgery if the patient has rumination, and we can check the status of the esophageal motility and the OJ junction when the patient has persistent symptoms after an anti-reflux surgery. Let's move now to reflux monitoring. Reflux monitoring can be done with a catheter, with several pH sensors, or with impedance sensors, or it can be done wireless by using an endoscopic procedure that fixes a pH capsule. This is called the Bravo capsule, but now there are other capsules in the market. Whatever the system you use, what you are interested in is to know how much acid comes into the esophagus. If you have a pH sensor in the stomach, what is the gastric pH, particularly interesting in patients that are on PPIs not responding to therapy. You can count the number of reflux episodes across the OJ junction, and you can investigate the association between reflux events and symptoms. Generally, we use two algorithms, the symptom index and the symptom association probability. Using all this, the aim of reflux monitoring in a subject is to identify the phenotype. Is this a patient with true NERD? Is this a patient with hypersensitive esophagus? Or is this a patient with functional heartburn? And why is it important to diagnose the phenotype? Because this will determine the treatment modality. And you will see that patients with NERD will probably respond to PPIs or anti-reflux surgery. Some patients with hypersensitive esophagus will also respond to PPIs, anti-reflux surgery, and pain modulators. But most importantly, we need to identify the patients with functional heartburn. In these patients, reflux is not the cause of the symptoms. And therefore, they should not be operated. And even more, they should not be treated with proton pump inhibitors, particularly for a long time, because you are not offering a real treatment for the problem. Now, let's discuss a little bit more about impedance pHmetry, which is the topic of my research and most expertise. And I would like to share with you a few novel data and new information. Impedance can distinguish different types of acid, weakly acidic or non-acid reflux episodes. It can assess gas-related reflux events. We can measure the status of the mucosa with a parameter called nocturnal basal impedance. We can measure the clearance of the esophagus after reflux, detecting what is called now post-reflux swallow-induced peristaltic wave. And interestingly, we can use impedance both off and on PPI, particularly on PPI in patients with refractory symptoms. This is an example of an impedance tracing where we can see little pH drops, acid reflux episodes, and impedance-detected reflux. And you can see that there are, before the drops in impedance, spikes. These spikes are due to air movement. Now, if you amplify the time scale and you check the direction of the spike of the air movement, you can distinguish between gastric belches and supragastric belches, and the diagnosis of supragastric belching is very important and new because this is a behavioral therapy that requires behavioral treatment much more than PPIs or anti-reflux surgery. And supragastric belching is associated with these pH drops that increase acid exposure. So many patients with what we thought in the past had typical reflux disease, in fact, they have a behavioral disorder that is provoking increased acid reflux. With impedance, this is an impedance tracing, we can measure what we call the baseline impedance value. In between swallows and reflux, there is a very stable impedance value. And that impedance value is determined by the status of the mucosa. When the electrodes are touching the mucosa and the mucosa is more leaky or damaged, the impedance values are low. When the mucosa is normal, the impedance values are high. And another parameter is the post-reflux swallow-induced peristaltic wave. You can see by impedance a reflux episode, which happens to be acid. Now, within 30 seconds of the reflux episode, there is a swallow. And that swallow is associated with an improvement in the pH, neutralizing the acidified mucosa. Now, this reflux episode is triggering a reflex swallow. This is a vagal reflex. When the esophageal mucosa is acidified, that triggers increasing salivary secretion reaching bicarbonate. The augmented volume of saliva in the mouth triggers swallowing. And this is within the 30 seconds after a reflex called post-reflux swallow-induced peristaltic wave. In normal subjects, this is very common. After each physiological reflux, there is a reflex swallow that corrects the acidity, and that is why a normal subject doesn't have symptoms or esophagitis. In patients with reflux disease, this reflex doesn't work very well. And we still are investigating the reasons why, whether this is secondary to mucosal damage or this is a primary phenomenon that provokes mucosal damage. In any case, when we combine these two parameters, we can improve the diagnosis of either hypersensitive esophagus or functional heartburn, particularly useful in patients where everything is negative. And we will see at the end that using these parameters can help us to discriminate the diagnosis. Now, we have recently improved the consensus or the diagnosis of reflux events by impedance. There was a problem with the automatic analysis of impedance. The software designed for automatic analysis is pretty bad. In general, over-diagnose reflux events. So we need to visually or manually edit what the automatic analysis of impedance measurements is doing. But in order to edit, we need to agree on what is real reflux and what isn't. So we have reached a consensus recently. This was published 2 months ago, where we have in this table the criteria that we need to use to edit an impedance pH tracing and delete all the false positive reflux detected by the automatic software. Furthermore, we identified now, after a very, very heavy work that collected all the impedance pH metry tracings from healthy asymptomatic subjects in the world. Look, these are all the collaborators in this study. And we look at what is really normal in impedance pH metry. What is normal in terms of acid exposure, number of reflux, PSPW score, baseline impedance, and we found that there are both system differences. In this case, these are two different systems, Sandhill and MMS, and there are regional differences. It's not the same, the normal values in Asia, in the West, and within the West, in Turkey compared to Netherlands. So now we have the first largest database that is compiling all the normal values in the world, and every lab now should check its normal values based on the region of the world and the system used. This was published 2 weeks ago in GUT. Another interesting use of impedance is the following. There are young women, particularly women, that complain of persistent regurgitation after meals in spite of PPI treatment. These patients are characterized as refractory reflux disease. Now, when we look at the impedance pH tracing in these patients, we identify a significant number of symptomatic non-acid reflux episodes that the patient is marking as a regurgitation. Young, particularly females with this pattern, have confirmed rumination syndrome in around 60% of the cases. This is also a very novel information. So when you have a patient that you treat it as a reflux disease with double dose PPI, the patient is persisting with regurgitations after the meal, you need to check the impedance pH tracing, because there is a chance that the patient doesn't have refractory GERD, but a psychological or behavioral disorder called rumination syndrome that deserves another treatment. What about Bravo or wireless pH metry? This is a very useful technique, particularly in the US, is used very often. It is very well tolerated by patients that don't like to have a catheter, and is very useful in a diagnosis of reflux disease. This is a technique that provides the possibility to measure for 48, 72, up to 96 hours and give you the possibility to know whether the patient might need to continue with PPIs or not. There is a discussion about what to use, either wireless pH monitoring or impedance pH monitoring. And this discussion many times is biased by non-medical situations, either insurance coverage, economic convenience in some centers, and so forth. What we tried to do was to try to get a discussion where when we should use this if there are no extra medical bias. And the point is to answer these two questions with these techniques. Does the patient have pathological gastroesophageal reflux? And why is this patient with previously confirmed reflux disease not responding adequately to PPI therapy? So the indications for prolonged wireless pH monitoring are the following. First, the patients always in wireless pH monitoring should be tested off PPIs. There is no Bravo on PPI. And what are the best indications? The first is patients who cannot tolerate a transnasal catheter. This is obvious. Then in patients with infrequent symptoms, once every 2 or 3 days or every 48 hours, where we need to establish a reflux symptom association. Then in patients that have a very strong clinical suspicion of reflux, but the 24 hours pH metry or pH impedance was negative. So that patient requires a wireless pH metry. And finally, when there is very low clinical suspicion, but both the referral doctor and the patient are convinced that there is reflux, and you really want to rule out GERD, so the patient is not treated further with PPIs or with anti-refluxage. What are the indications for impedance pH monitoring? This is a technique that can be used both off or on PPI, particularly important in patients with refractory, typical or atypical symptoms, despite of PPI therapy, but only in those that have documented reflux disease, either by endoscopy positive, grade B, C, or D, or Barrett, or peptic stricture, or if they had a previous positive pH testing. In patients with respiratory symptoms or respiratory disease that is potentially triggered by reflux, for example, cough, or in patients that are prone to deterioration from reflux-related microaspiration, pulmonary fibrosis, cystic fibrosis, and post-lung transplant. Why? Because in these patients, non-acid reflux has been demonstrated to be also responsible, and Bravo will not recognize that. As I said, in patients with repetitive belching, with or without concurrent typical reflux symptoms, and in patients with suspicious of rumination with increased postprandial regurgitation that were refractory to PPI treatment. Finally, in patients with increased belching or persistent symptoms after anti-reflux surgery or endoscopic procedures. There is another technique in the street these days, which is so-called mucosal impedance. This is one catheter passed through the endoscope with a pair of electrodes. This technique is measure the mucosal impedance, and the authors claim that they can discriminate reflux disease from eosinophilic esophagitis and achalasia. This is a very interesting technique. I only find that there are two limitations. I don't think that it can explain clearly refractoriness, and it does not allow to measure reflux symptom association analysis. What about pepsin? We studied pepsin in saliva a few years ago, and in our first studies, we found this technique very interesting with a low sensitivity, but a good specificity for reflux diagnosis. Unfortunately, when we try to reproduce these results years later, we couldn't. The manufacturers changed completely the antibodies used and the technique for detection, and we found results all over and without any discrimination between phenotypes, both in adults and in children, and we came to the conclusion that this technique conceptually is very interesting, but it's not ready for clinical application, and of course cannot be used to decide whether a patient should have anti-reflux surgery or not. So this is the Lyon consensus. The Lyon consensus is a very interesting work by a large group of experts in the field, and we came to the following situation. When you have a patient with endoscopy positive, C of the esophagitis, Barrett or peptic, and acid exposure above 6%, this is a conclusive diagnosis of GERD. On the other side, if you have a patient with endoscopy negative and the acid exposure is less than 4 and the number of reflux episodes is very low, this is clear that the patient does not have pathological reflux. So what we need are adjunctive or supported evidence like electron microscopy, low mucosal impedance, the reflux symptom association analysis, the low baseline impedance, a low PSPW, some manometric features that are in favor of reflux disease. And with all this, we can move the balance from patient that we are not sure if it is reflux or not, and we can move it to reflux or non-reflux. At this moment, it's very important the definition of refractory reflux disease. So there are two situations. One situation is where the patients have refractory reflux-like symptoms, but the patient has never been proven reflux disease. And another is in patients that did have a documented reflux disease by endoscopy or pH-metry. So the concept of refractory GERD is related to this group, to the patient that had documented GERD. And they had documented GERD as a esophagitis, peptic stricture, long segment Barrett esophagus, or abnormal acid exposure. They need to have symptoms not responding to a stable standard dose or double dose of PPI for at least 8 weeks, and they need to have at least less than 50% reduction in the frequency or severity of the symptoms. And this is my last slide. This is a very interesting algorithm for patients with persistent symptoms on PPIs, and this was a recommendation from a expert panel in the US published in 2018. So this is a patient with proven pathological reflux with PPI unresponsive symptoms despite 8 weeks of double-dose PPI therapy that is having a pH monitoring on double-dose PPI. And there are different possibilities: esophageal acid exposure, symptom reflux association, number of reflux episodes, hiatal hernia, predominant symptoms, and the type of treatment. So the acid exposure can be elevated or normal. If the acid exposure is elevated in spite of the PPIs, then we look at the endoscopy and we decide whether the patient has a large hernia or not hernia or small. If the patient has a large hernia, the possibility that that will improve with a laparoscopic fundoplication or magnetic sphincter augmentation is good. Otherwise, we can treat the patient with non-invasive treatment like H2 blockers or baclofen. If a patient has no hernia, then this invasive scenario is more doubtful. It's better to go for non-invasive treatment. In contrast, if the patient has a normal acid exposure, here we are dealing with the two possibilities: positive symptom association, which is a reflux hypersensitivity, or negative symptom association, which is a functional heartburn. In the positive symptom association, again, you look at the presence of large or small hernia. The type of symptom is predominant heartburn or predominant regurgitation. In general, the predominant regurgitation will respond better to laparoscopic fundoplication, and this is the same in patients without hernia. And finally, the patient with negative reflux symptom association is the same concept, but instead of looking at the presence of other impedance parameters, we look at the number of reflux episodes. When the patient has a large hernia and a high number of reflux episodes, then we, in this particular case, functional heartburn, we rarely recommend invasive intervention, and they should be treated with TLSR inhibitors like baclofen or neuromodulators or CBT. So this is my last slide. This was my group last Christmas. Unfortunately, we will not be able to meet for this Christmas, but let's see, maybe next year. Thank you very much for your attention.
Thank you very much, Professor Cifrim, and I hope the next Christmas will be together here in Zagreb, and that we could show you this our marvelous town. So thank you very much for this excellent lecture, and everybody in Croatia was listening to you. But even though that this is a state-of-art lecture, we'll take the opportunity to ask some questions. Probably Agata is eager to send you some questions. So can I, Agata, I'm calling you now.
Yes,
okay.
Dear Professor Cifrim, thank you so much. I was so happy to see you and to hear you again. So you had the really excellent lecture and so concise. I prepared some questions yesterday, but today everything is mixed again. I think that we all have picked something which was interesting to us today, listening your lecture. So if I can ask you just a couple of questions.
Yes, of course.
So, first of all, congratulations to your new studies. I still haven't read them, but I hope I will soon. But can you tell me to what do you ascribe the difference in impedance between Asian countries and European countries? Do you have anything that you could stick to? Why do you see these differences between impedance?
I didn't have time to discuss the numbers, but in general, in Asian countries, the baseline impedance is higher, suggesting that the mucosa is tighter and stronger, and that can explain why there is much less esophagitis and Barrett in China and in Japan compared to European countries. On the other side, in Turkey, for example, the baseline impedance is much lower. And I think that this is something that is a genetic issue, and probably also differences in meals.
Okay.
Other interesting things are, for example, in South Africa, the number of non-acid reflux episodes is much higher, and this is definitely due to a diet component. We already knew that, and there are papers from South Africa showing it as well.
So
what I want to make sure is that the concept that the normal values are the same all over the world, that was imposed by the pH metry in the past, is incorrect. Each country, each lab should establish its normal values based on the region of the world and the system that you are using.
So we should use first normal values, do normal testings, and then to see what is our referral value actually. Each country. No,
I think that you, being in a Western country, you can use what people in Italy, in Spain, and in Belgium, and in the Netherlands are having. This is more or less similar. You don't have to have your own normal value.
Okay. And the second question, I don't want to take time from other. Sorry?
Just anybody from other viewers, I have to stress the point that they can contact us by the chat, other viewers again, and they can ask all the questions. What we will ask Professor to answer that afterwards, and we will do this way. Okay, Agatha, continue.
Just one more question just to give the room other participants. I think that we have problem with the treatment of hypersensitive esophagus, and I know that you had some people, psychologists in London, that they were using cognitive behavioral therapy. Do you have any other treatment possibilities, or I don't know, because here in Croatia we don't have experts in that field which would do hypersensitive esophagus treatment?
Well, one thing that you need to understand is that hypersensitive esophagus is a very heterogeneous group. They are not all the patients the same. I would divide it in two. The true hypersensitive that will require pain modulators, imipramine pain modulators. And those that have behavioral disorders, not hypersensitivity, let's say molecular hypersensitivity, but more a psychological behavioral disorder. The way to differentiate these two is looking carefully at the impedance pH metry. If the impedance pH metry shows you that the patient has a lot of belching related with symptoms, rumination related with symptoms, or hypervigilance related with symptoms that you can distinguish, that patient will require both the pain modulators and a psychological approach. And this psychological approach doesn't need to be a specialized psychologist. There are a few videos in YouTube. If you want, I can send you. And you need to sit down yourself with a psychologist with a little experience in CBT and learn. This doesn't need to be done by psychologists. I am doing it myself. My fellows are learning to do it. And it takes half an hour. It's not an enormous investment of time. So I think that you don't have to feel that you need to have a super specialized psychology department to teach patients doing diaphragmatic breathing and modify the mouth opening.
Great. Thank you.
Thank you very much. Anyone from audience or our round table?
Hello, Nadan. I have one question or maybe two questions.
Okay.
Is it
Professor Jucic from the Holy Spirit Hospital Clinic.
For Professor Cifrin, how are your experiences with wireless pH metry, and how often you use it on a regular basis?
Well, we are in our department, we have a GI physiology unit doing mainly catheter-based reflux monitoring. And we have in the gastroendoscopy department a group that is the endoscopists, and they are doing wireless pH metry quite often, several per week. And the indications, as I said, are different. When there is a typical reflux symptom, heartburn or regurgitation of chest pain, I think that wireless pH metry is very useful. No doubt about that. My concern is in patients with atypical symptoms, particularly regurgitators, belchers, ENT symptoms, pulmonary symptoms. In those patients, I would not recommend wireless pH metry. I would go for a simple 24 hours impedance pH metry that will provide you the information of acidity on the one hand, and the information of belching, proximal extent of reflux, potential risk of aspiration. These are different information that the wireless pH metry cannot give you. So they are not exclusive one from the other. They are complementing techniques.
Thank you.
Please, do you record any complication by using the wireless capsule? It's more invasive than the standard manometry and pH metry.
Professor
No, the complications are very infrequent, very infrequent. The most common is the detachment of the capsule. But in general, these are very innocent complications. We don't have experience with chest pain or severe complications with the Bravo capsule, no.
Thank you.
Thank you very much, Professor Sifrim. I know that you are, thank you really very much that you have another lecture in a few minutes, so we'll have to wrap it up. And thank you. Hope to see you again.
It was my real pleasure. I would like to congratulate you for your meeting, and I hope that we'll be successful during the day today. And I look forward to meet you personally in the future. Bye-bye.
Thank you very much. And now it's my really great pleasure to introduce my friend and our teacher, Professor Alessandro Txi, director from Endoscopy Unit in Humanitas Research Hospital. He graduated medicine and surgery in the following year. He won the scholarship in the Department of Gastroenterology, Molinetti Hospital in Turin. Where he begins his practice in digestive endoscopy. And also in 1992, he was working with Claude Ligorian as a fellow in American Hospital in Paris. In 1994, he became a specialist in gastroenterology and digestive endoscopy in University Messina in 1995 and practiced at the Department of Gastroenterology, Ospedale Maggiore Molinette of Turin. In subsequent years, he has been working with at the service of digestive endoscopy, Dell'Antona Hospital in Hamburg, directed by Professor Hagen Miller, and after that in gastroenterology, Molinette Hospital in Turin, directed by the Professor Risetto. The clinical activity and research of Professor Txi, in which he is well known in the world, is mainly to the development of new diagnostic and therapeutic techniques in the field of the diagnosis, and particular attention he paid to the methods on endoscopic removal of early cancerous lesions. So Dr. Txi collaborates with a lot of projects in the field of endoscopy in your university in Rotterdam, New York, Haifa, and in several other hospitals in Italy. He serves as a reviewer and in many gastroenterology journals, and has co-authored in more than 350 articles. It's our great pleasure to have him as our teacher, to ask him to speak about the role of endoscopy in functional GI disorders. Ale, thank you very much, and sorry for little. Tomislave, možemo imati profesora sada.
Da, može početi pričati.
Ne vidim.
Samo ne početi pričati.
Yes, you can start, Ale.
So, thank you, Alan. Good morning, everybody. Can you hear me?
Yes, we can hear you quite well.
Thank you, guys. Thank you, Alan, for the beautiful introduction, which I do not deserve at all. And also, congratulations to Sifrim. He did a great lecture, as always. I love to hear all the time innovation from Sifrim. So, guys, it's a difficult time for everybody. I've been working since the last 2 days in the COVID, so I'm quite tired, a lot of work to do because we are overwhelmed with COVID cases. We have more than 300 patients admitted right now in our hospital. So I'm so glad I can join virtually Zagreb. Hopefully I will come visiting you next year, if it will be possible. And my task today is to talk about endoscopic treatment of these motility disorders. So these are my disclosures relevant to the topic of my presentations today. So I want to start showing a case they have been treating last month. So this was a patient, older female with a Parkinson's disease that was being treated just and fed just using a nasogastric tube, including the pills for Parkinson, for this severe dysmotility of the entire esophagus. She was referred from southern part of Italy. She came to Milano in the middle of pandemic just last month. We looked into these pictures and we say, what we can do. Okay, the solution is that now endoscopy has huge potential in doing very minimal invasive treatment for these patients. So we performed the POEM on 19th of October, it was Monday morning. It took about 1 hour and I did a long myotomy. I cut all the way through the esophagus. So I did myotomy from the upper sphincter to the lower sphincter. And the patient had this poroseries afterwards. So 2 days later, she was discharged, super happy, soft diet. She called me a couple of days ago saying for the first time in years, I was able to eat pizza plus mozzarella. So this is why we're talking about that. So we started esophageal dysmotility since a long time, and our team, altogether with Muinka Shab from Johns Hopkins, published in 2015 the first paper on POEM spastic esophageal disorders, showing already 5 years ago that POEM is an excellent resource, an excellent therapeutic modality to treat these patients. Solution of the third space. We as endoscopists were used to work in the first space, luminal endoscopy, the second space, cholangioscopy, pancreatoscopy, and now we have the third space, which is endoscopy in and outside the gut wall. So basically, the two inventors of the third space endoscopy are these two American guys, Briscoe Stout, that has been retired since a couple of years by serving as a medical director of Apollo company, and Jai Pashrika, who is a brilliant gastroenterologist who has done a lot of new development in the field of gastroenterology and endoscopy. And this is Jai Pashrika presenting in our hospital how he did the first attempt of submucosal tunneling and myotomy in a pig. So, and I was very lucky that I spoke with him and with Aru Inoue about the creation of POEM. I hope you have the audio. So as you can see, Aru Inoue was the first, creating the name POEM, peroral endoscopic myotomy, and afterwards this became the beginning of a big evolution in the field of third space. So also Inoue reported the first in endoscopy 2010, very limited series, but with outstanding results, showing that that was the way to go through. And he reported in that article these beautiful drawings and pictures showing the technique. So there has been an evolution in indication. Originally, it was proposed only for type 2 uncomplicated achalasia. Now we have a huge number of indications. As I've demonstrated to you, we use also for spastic disorders. We have been using in pediatric patients in favor of Heller-Door treatment. And in terms of technique, everybody knows is in general anesthesia. You have a mucosal opening, submucosal tunneling, myotomy, and afterwards the mucosal closures with clips. So there is a lot of discussion about how to do myotomy. This is a typical myotomy I'm performing one of my patients. So it's anterior or posterior. So there are experts saying that anterior is better than posterior and vice versa. So there have been a couple of prospective trials and a meta-analysis published on that, looking into procedure complexity, incidence of complication anterior versus posterior, reflux, postoperative pain, long-term outcome. All of them are equal. So whatever you're choosing is anterior or posterior, all of these will be very similar with the exception of postoperative pain. We know that pain is a little bit reduced in the posterior myotomy. And this was confirmed in a meta-analysis being published in Endoscopy a couple of months ago by Doug Hadler. He was reporting that there is no consensus among experts. Normally, we do full thickness distal myotomy in most cases. Posterior approach is the most most indicated for post-Heller patients, and anterior is still 75% of patients as preferred by all experts. So what about the outcome of POEM? The largest paper was published about 5 years ago, 500 consecutive patients from Tokyo, from Inoue centers. They reported their first single center experience. You see they did a significant number also of sigmoid patients. So what about the early outcome of these 500 patients? So complication rate quite low, 3.2, mean follow-up 3 years. They reported 60% of GERD and persistent clinical response in 90% of the patients. It is nice graphic showing the significant improvement in the dysphagia Ecker score after POEM. So the first European data, robust data, came in 2015, published by 2 groups, Guido Costamagna and Thomas Rochel together. They reported their data. And again, they reported nice outcome at 2 years with about 80% with a persistent improvement of symptoms. And with regards to reflux, we were the first to publish a large, very large meta-analysis looking into reflux. And we have to admit that about 1/3 of the patients, they are going to develop some form of reflux after POEM, with half of them having reflux that is very easily treated with standard doses of PPI. In the meantime, 2 big randomized were published, the first in JAMA 2019, comparing POEM with balloon. You see, when they looked to the outcome was very similar in the early stage, but with a significantly reported increase of reflux for the POEM harm. But when they looked to the long term, you see 126 patients followed up for 2 years. The success rate of POEM was almost twice bigger than pneumatic dilation. So POEM works in the long term. Of course, again, there is the issue of reflux. And finally, this is the New England paper that is being published by a European consortium led by Thomas Roche. We were part of that study. We contributed significantly with that study and reporting a comparison between POEM and laparoscopic. In the long term, up to 24 months, there were no differences at all in terms of persistent control of dysphagia. And when we looked into the data, you see the MIST score was very similar. And daily PPI was a little bit superior in the POEM group, either at 3 months and at 2 years, but we got more reflux patients. You need to be prepared to have more reflux when you do POEM, even though the acid exposure time, because all of these patients underwent pH evaluation at 6 months and 2 years, the pH study wasn't too much different when POEM was compared with myodom. Of course, when you do POEM, you need to be prepared with adverse events. The most frequent adverse event, they were reported first in a very beautiful paper in 2018 by Aru Inoue. There may be mucosal injury, perforation, problems with the tunneling, bleeding, pneumothorax, and pleural effusion. So this is a very large report of adverse events associated with POEM reported in American Journal of Gastroenterology. You see 2.6% of patients may require surgery. And there are no data about mortality, but what we know that there have been a couple of patients around the world who have died because of POEM. Of course, when you do POEM, there may be incidental findings of capnoperitoneum or capnothorax or capnomediastinum, but these are not complications really. It's a physiologic I would say, exposure of CO2 to peritoneum or thorax or mediastinum. It's important that you know the adverse event they can present mostly during the procedure or in the first 48 hours. Very limited number of complications, they can come lately. And you can see just 9% of all procedures reported a complication later than 48 hours. So what are the predictors that can tell you that the patient has increased risk of developing complication? Of course, a sigmoid type. The other problem is technical skill. If you have performed less than 20 POEMs, you may have more number of complications. Also, the use of the TT9 is a risk of complication when compared with the hybrid. And finally, there is a use of current modality different than spray that's been associated with increased risk of complication. So these are our complications. This is the report of what we have done. I would say that there is an increasing number of patients treated with POEM, either for achalasia or for other disorders. It is the overall number of complications that we have reported. As you can see, we are very similar to the American Journal of Gastroenterology data. We are around 2.5% of complications. These are a couple of complications, saying that sometimes everything looks good, but in 2 days, a patient was having big pleural effusion. And this is day 4. We looked at that. There was all clips were fall down. We had to close again, but we were not able. This is the only patients that have been referred in our unit to surgery. It required thoracotomy plus washout plus drainage. It did very well. It was discharged after 10 days. And this is another patient I want to report how we did with complication. You see again, he developed chest pain, but very severe chest pain and not responsive to therapy. got fever. So I had to look to the endoscopy. I see here, this is the tunnel. So the tunnel was totally infected. I cleaned the tunnel. I washed it entirely. I put a pleural tube, and afterwards I placed an esophageal fully covered metal stent, large size, tried to compress the tunnel. He did extremely well, was discharged again in 1 week. We removed the stent in 2 weeks. So this is another complication that we got. We did a procedure. Patients started having melena and lipotemic episode. His hemoglobin dropped down by 8 points. So this is the endoscopy I did. So mucosotomy looked very good. I put the scope down. I was advancing the scope, and I didn't see blood. But at a certain point, you can see I recognize this huge mucosal, submucosal hematoma. I put again the scope down, and this is at the cardia in retroflexion. There was big clot. I really was scared. There was a huge mucosal gap. So the clot is created a very large hole into the cardia, and I tried to remove that. But at a certain point, I recognized I could not do anything. So I left the patients like it was, and he recovered alone without doing anything. Just I put him on parenteral nutrition. I did antibiotic therapy. I controlled it 2 weeks later. It was like a miracle. So like nothing had happened. So of course there are a lot of data coming about POEM after failure of Ehlers-Danlos, and I must tell you that I've just finished an editorial for Gastrointestinal Endoscopy reporting the data on failure of Ehlers-Danlos, and POEM works extremely well in patients after failure of surgery, with about 80% reporting very good outcome also in the long term. Of course, we have advanced ourselves in the third space. This is a video to show that going in the third space, we have a lot of opportunities. This is submucosal tunneling to remove large GIST lesion into the esophagus. You see, we're using a hybrid knife, but we have isolated completely the large GIST. The main problem was just to take out the GIST, but at the end, we were able to remove entirely and to clips afterwards, because and to close the mucosal entry, this was a little bleeding point that we controlled using the COA grasper. So also the other opportunity with the third space is G-POEM. We are doing G-POEM now on a regular basis. This is the pyloric ring. We use this knife, this Olympus knife, which is protected by a ceramic ball on the tip to avoid deep thermal injury. And we do myotomy for about 1.5 to 2 centimeters, no longer than that. In G-POEM, you don't need a long myotomy, always on the greater curvature. You have to pay a lot of attention to vessels, because there are very big vessels outside the stomach. You cut one of these vessels, this can be a big problem. You see afterwards very easy advancement of the scope across the pylorus, and finally the closure using multiple clips. So we have published very recently, 6 months ago, the largest systematic review on early outcome of G-POEM. Unfortunately, there are only retrospective series, so we got data after about 10 studies, and there was a different definition of outcome. That was the main problem with our systematic review. Positive outcome was defined in different studies, but anyway, we reported a symptoms improvement 84%, a complication rate of 4.6%. The other innovation of endoscopy managing esophageal dysmotility disorders is that poem that's been reported first by the Shanghai group in gastroenterology, and we have changed the paradigm. Now we're doing it differently. We do not do the incision in the upper pharynx, but we cut directly the septum. You see, I have injected the septum, and I'm trying to expose the septum, and I go deep down into the muscle. You see, once you have created a tunnel, you can go very down, and I cut fiber by fiber by fiber. Let me go quickly. This is almost the end. You see, I have cut the esophageal muscle for about 2.5 centimeters. At this point, the esophageal muscle becomes thin, very regular, and there is nothing to be cut at the end, just a couple of clips, and the work is done. We do this as outpatients, so we discharge the patient in the same day. We were the first to publish in endoscopy this here, the largest number of patients prospectively followed for this technique, the POES, and we had 20 patients, 100% of technical success, no adverse event, 19 out of 20 patients doing extremely well after more than 1 year follow-up. This was my last slide. I hope I covered efficiently the topic and you were able to follow my presentation. Thank you so much, everybody, for your kind attention.
Thank you very much, Professor Txi. Excellent lecture, and we are always used to hear those lectures from you, and really probably there are a lot of questions about that, and actually I see that Hrvoje Iveković is eager to have a question. So Hrvoje,
please go ahead.
Hello.
Hi.
Hi. Hello, dear Professor Txi. Thank you very much for a very nice presentation and very systematic manner. Actually, I have so many questions, but if I may use this opportunity to ask you a couple of them. First, is there any preferable accessory that you use in performing poem? Is it a dual knife or a hook knife? Is there any accessory preferred?
That's a very good question. Technically, it's important. So we use a hybrid knife from Herbie, which allows us to inject and cut for poem, and we use a coagrasper for coagulation of bleeding points. Finally, we use a 360 resolution clips from Boston because it's very easy to rotate the clips and have a very secure closing of the mucosa. And for POES, peroral endoscopic myotomy for Zenker, we use the hook knife.
Thank you. The other question, if I may, do you see any use of prophylactic use of, do you see any value in prophylactic use of antibiotics?
That's also a very good question. We started doing this using all the time prophylactic antibiotics. We have done a study, we compared the prophylactic versus non-prophylactic, and we didn't see any advantage in using prophylactic antibiotics. So right now we do not use antibiotic at all. The day after we do white cell count and protein C dosage. If everything is well, we discharge the patients on day 1 without any antibiotics.
So you perform poem as an outpatient base?
We do poem in the afternoon of Monday. We do 3 cases every week, and we discharge the patients on Monday, on Tuesday morning, the day after, because according to the Italian rules, we don't get reimbursed if we don't do in operating room. So we cannot do in endoscopy space. So the surgeons, they don't give us the operating room in all days, only on Monday afternoon. We are just neglected, so we can use only that space.
So that is a quite different situation from Croatia, because our surgeons, they do let us in their surgical theater, As long as they don't.
But that will be much better. You can do it after.
As long as they
great.
don't.
I will come to Croatia working. Okay, that's great.
So, please be welcome to do. And final question, if I may, and thank you so much for your kind attention. So with this new technique that you just explained, this POES in treatment of central diverticulum, to your knowledge, are there any comparable studies between endoscopic diverticulotomy and POES?
That's a great question. We all together with Michael Kaminsky, Thomas Roche, Muinka Shab, we are organizing a multi-center trial to compare the two approaches. And right now we are publishing our data in American Journal of Gastroenterology. We are publishing data on 400 cases of Zenker. We are probably the center doing more Zenker in the world. We do one case every day. So we do 5 Zenker per week normally. We do about 150, 200 cases per year. And we are thinking to do a retrospective analysis of the POES versus traditional septotomy. But in the future, there will be data from the randomized trial we are running at international.
Thank you very much, Ale. And Professor Babic.
Thank you, guys. Thank you, Nathan. You have been very kind. Stay safe, everybody, please.
Professor Babic has one more question.
One short question. The avoidance of anticoagulant therapies, perhaps like in the other invasive endoscopical gastroenterological procedures, I suppose.
Did you hear, Ale, the question?
Oh, yes, you're right. So the use of so we have more and more, we have hold patients, especially with the Zenker. The question? I cannot hear.
You can,
sorry, I cannot hear.
Yes, can you repeat the question, Professor Babic? Professor Babic. Okay, Ale, thank you very much for your support.
Thank you so much, guys. It's been a great pleasure. Congratulations for your meeting and stay safe. Ciao, ciao. Love to Croatia.
Ciao. Okay, we continue with our program, and now we have a round table. It was previously supposed to be the kind of practical work in an operation room, but according to this epidemiological situation, we make that on a video clip. So I'm calling Agata Ladic to announce the round table. Prior to that, I want to greet the ex-president of SGINA, Jadranka Brljak, to say hello to our audience. Jadranka, please.
Hello. Dobar dan svima.
Okay, we can continue, Agata, now and start.
Okay, so once again, good morning and good day to everybody. I would just like to thank to all the lecturers whom we have heard just a few minutes ago. We have decided to show a couple of films about pH manometry, pH impedance and manometry, but in advance, we will just continue our meeting in Croatian language. But should there be any questions, please don't hesitate and just put your questions in the chat box and we will try to translate them and answer them properly. So now we will see our young colleague, Mislav Jelakovic, who will present pH metry with impedance. Dobro jutro, Mislav.
Dobro jutro svima.
Evo, ako možeš, evo,
samog postavljanja pH katetera potrebna je kalibracija i priprema samog katetera i aparatića. U softveru nađemo odgovarajući kateter koji smo odabrali za postavljanje kod pacijenta. Kada izaberemo opciju katetera koja nam je nuđena, moramo kalibrirati sam kateter. Prvo ide u neutralni medij, zatim u pufer koji je pH 401 i u drugi je pH 7. Evo sad počinjemo kalibraciju koja traje 10-ak minuta.
Sfinktera jednjaka i na tom mjestu se fiksira. Kateter dakle ostaje pozicioniran u jednjaku do idućeg dana. Minimalno da bi mogli imati adekvatnu snimku je znači potrebno 17 sati snimljeno. Nakon postavljanja katetera, kao što sam rekao, on je fiksiran na određenoj poziciji i nakon toga bolesniku dajemo upute kako se rukuje sa aparatom, to je, ajmo reći, kao holter izgleda kojeg bolesnik ovako nosi oko ramena ili oko pojasa, te ima na njemu tipke uz pomoć kojih može zabilježiti simptome, početak i kraj obroka i može označiti dakle kada leži ili kada miruje. Uz to također pacijent dobiva i dnevnik na kojem na papiru on zabilježava svoje simptome, hranu, tekućinu, lijekove, sve što unosi i to nam je poslije bitno u analizi same snimke pH-metrije radi korelacije simptoma, hrane, tekućine. Evo na videu se vidi objašnjavanje svega toga bolesniku.
Hvala. Mislav, je li možda sestra Jelena blizu da ona dođe sa sestrinske strane rečenicu dvije samo reći što misli da bi bilo zgodno da sestre znaju oko pripreme kalibracije katetera?
Dobar dan, ja sam Jelena. Evo ono što je bitno, a nisam naglasila u prethodnom klipu, je da kateter se mora kalibrirati ovisno o svojoj vrsti. Ono što je bitno da oni svi podliježu tjelesnoj temperaturi, tako da vanjska temperatura okoliša nije naravno identična ljudskoj temperaturi. S obzirom da je fiziološka usklađivanje temperature nemoguće dobiti u standardnim uvjetima, onda u samom sustavu su već određeni neki gabariti. Pa tako po vrsti katetera se određuje i kalibracija, odnosno rok traja, odnosno koliko će ta sama kalibracija trajati. S obzirom da danas pričamo nešto više o impedancijskim kateterima, sama kalibracija traje 10 minuta. Znači u neutralnom mediju koji je na sobnoj temperaturi, ne smije biti vode, znači tog medija niti topla, niti hladna. To je ovako specifičnost svakog katetera na osob, pa evo jedan ovako za impedancijski mogu reći.
Hvala Jelena. Ima još nešto? Oko sterilizacije, znači drugi dan kad pacijent se vrati s kateterom, ako možete reći samo što napravite sa kateterom idući dan.
Mi imamo katetere koje koristimo za jedan pacijent, jedan kateter, znači nemamo za višekratnu upotrebu, jer oni u principu nisu impedancijski, pa evo, nemamo tu mogućnost, odnosno nismo se odlučili na to još.
Evo, hvala lijepo za sad. Evo ga, ja ispred Zavoda za gastroenterologiju i hepatologiju lijepo pozdravljam sve naše sudionike koji su se vrlo spremno odvažili biti dio ovog virtualnog okruglog stola, prvenstveno profesora Babića iz Dubrave, profesora Jurčića Svetog Duha, doktoricu Anu Močić-Pavić iz kliničke bolnice za dječje bolesti, te doktora Vanju Licula iz kliničkog bolničkog centra Rijeka. Pa evo možda prvo pitanje s moje strane profesoru Babiću. Profesor Jurčić ovaj čas ne vidim, ali profesore Babiću, ako nam možete reći vaše iskustvo baš oko vrste katetera, znači mi najčešće koristimo ili kateter samo sa pH senzorima ili katetere sa impedancijom koji nam daju puno više informacija zapravo, no zbog cijene nismo uvijek u mogućnosti postaviti taj kateter sa impedancijom. S obzirom na vaše dugogodišnje iskustvo i znanje, nam možete savjetovati, odnosno reći kako vi pristupate tom problemu? Kome koji kateter? Ne čujemo vas. Ako možete uključiti mikrofon.
Aha, oprostite, evo ga, uključen je. Dakle, ako je poprilično jasna stvar, a radi se o čistom dokazivanju i nekakvom simplex isključivanju nekih drugih stanja, s obzirom isto na financijsku situaciju, koristim pH-metrijski kateter sa 2 odvoda, standardni. Za sve ostalo gdje je potrebno, ili ponovim nakon toga ako mi nešto nije jasno sa impedanca kateterom, ili kod stanja gdje bi moglo se očekivati motorički nekakav poremećaj, o čem smo i malo prije slušali, eventualno sumnja na hipertenzivni jednjak ili u sklopu dispepsije, onda svakako koristim impedanca kateter. Ovo je jedna zgodna dogodovština koja je bila zapravo, svi smo postali pametniji za toga, ali eto da informiram i ostale. Jedna mlada bolesnica koja je u jednoj drugoj ustanovi tretirana do svoje 19. godine kao ahalazija, na kraju ispalo je nešto sasvim drugo. Dakle, to nije bila ahalazija, to je bio rigiditet od vani izvan Hrvatske prvo postavljena ahalazija manometrijski, ali na kraju kad smo radili impedancama pH-metriju, to je ispalo nekih 4 miliona impedanca događanja. Dakle, radilo se dole o rigiditetu donjeg dijela jednjaka kao posljedica fibroze. Dakle, vrlo uznapredovali refluksni ezofagitis. Njoj je uvedena vrlo žestoka antirefluksna terapija nakon toga. Motorika jednja se popravila, dakle onaj distaktilni kontraktilni integral je porastao, onaj DCI je porastao, nešto je dobila i brzina jednjaka, kardija je bila dilatirana pa slabije se i dalje otvarana, ali simptomi su izgubljeni. Dakle, apsolutno impedanca kateter može preokrenuti potpuno dijagnozu. I mislim da kod takvih stvari apsolutno treba impedanca kateter koristiti. Problem je u cijeni. Eto, to je svima, i vama i nama. Dakle, moramo prilično biti racionalni sa korištenjem impedanca katetera. Gdje god možemo upotrijebiti klasični pH-metrijski kateter, upotrijebiti jer je ogromna razlika u cijeni. Upotrijebiti ga, ali gdje postoji razlika, tu moramo svaki za sebe u svojoj glavi razmisliti, odlučiti. Idemo na impedancu, napravit ćemo impedancu. Velim, nekada od prvog akta, ako sami oni parametri, jer uvijek klasičnu manometriju napravite prije toga. Dakle, ako vidite da nekakav ne samo neklasificirani motorički poremećaj postoji, nespecifični motorički poremećaj, onda svakako impedanca kateter, da, slažem se.
A što se tiče postavljanja samog katetera, znači postoje neke formule napisane u studijama ako nemamo napisano Z-liniju gdje se nalazi ili slično. Jel se vi više orijentirate prema Z-liniji na gastroskopiji ili radiološkim metodama evaluacija pozicije katetera ili evo po formuli koju ja možda najčešće koristim jer me tako najjednostavnije?
Uglavnom se koristim tako što prvo napravim manometriju. Dakle, vidim gdje je donji sfinkter jednjaka. Problem je kad je on inkompetentan, kad je velika hijatusna hernija, kad je sfinkter unutar hernije, onda to radi se i prema Z-liniji, da. Može se i prema formulama. Dakle, prvenstveno manometriju napravim, tako sam od uvijek radio. I to je nešto što je prilično točno i sigurno. I druga je stvar, kad idem s kateterom, nastojim sa samim kateterom provjeriti padove vrijednosti pH. Dakle, nikad nije to sa jednim odvodom, to su uvijek kateteri sa 2 odvoda. I onda kad dobijem nagli pad pH, koji opet upozoravam ne mora biti, jer ako je čovjek na inhibitoru protonske pumpe, tu znamo imati velikih odstupanja. Na kraju krajeva poslužim se i trećom metodom. Paralelno s kateterom uđem endoskopom, pogotovo recimo ako je pitanje i nekakve ahalazije. I puno puta, ja uvijek imam endoskopski stup pored sebe. Dakle, puno puta moram ući i endoskopom i onda provjeriti poziciju. i dok sam s endoskopom mjerim tu poziciju, upozorenje svima kad vadite endoskop, kateter će vam se uvijek pomaknuti, ali baš uvijek pomaknuti. Dakle, kad izmjerite onu dužinu koju ste imali uz endoskop, a vidite da nije nigdje savinut kateter, da nije gore u faringsu smutan, da dole nije presavinut, onda tu dužinu uzeti i na taj način ga pozicionirati. To je kod ovih stvari gdje se praktički ne može odrediti. Idem na vizualizaciju, vidim mjeru koju sam dobio manometrijom i onda to tako određujem. Naravno, kod ovih ostalih metoda koje radim, antroduodenalna i tankocrijevna manometrija ili kolon manometrija, tu uvijek uz pomoć endoskopa radim. To je nemoguće jer moram klipsati kateter u debelo crijevo ili dole u tanko crijevo.
Da.
Ali prvo treba biti oprezan, velim ih od tih stvari kad se izvlači kateter, to su hemostatske klipse koje vam se potrgaju. I onda nekad čak treba i 2 provjere, pa onda to zahtjeva duži period odmora. Tako velim i kod jednjaka kao i kod ovih drugih. Kad ne ide drugačije ili kad je ahalazija, onda jednostavno proguram taj kateter uz endoskop nekako. Klješljima, velikim aligatorskim klješljima i polako ga utiskujem unutra. Evo, to bi bilo.
Jeste li vi razmišljali o ovoj wireless kapsuli ili ne? Mislim da
Jesam. Puno sam razmišljao i o wireless kapsuli koja se mjeri i pH i temperaturu radi vrijeme prolaska. Sad imamo Olympusovu kapsulu koja i 3D prikaz daje, dakle topografski prikaz. Želja mi je ta wireless kapsula, razmišljam o njoj, samo treba prvo razmisliti i treba ju kupiti.
Da.
To je svima nama zapravo uvijek isti problem. Doći do novaca, ono kad se nabavi oprema, onda opet tu opremu nadopunjavati, obnavljati, to je stvarno problem.
A na koji način zapravo Riječani pristupaju problemu katetera? Mislim u smislu vjerojatno isto o cijeni vodite brigu i da li imate neke indikacije specifične kod kojih ćete postavljati sam pH kateter ili jednako kao što i mi zapravo u Zagrebu se mučimo s cijenama?
Licula. Dajte Agata uključite doktora Licula.
Ali uključen je, evo upravo da ti...
Tomislav ne zna da je on Riječanin.
Aha, pa ja mislim da on samo može se unmutati.
Da li me čujete?
Da.
Čujemo vas.
Halo?
Doktor Liculi, ja sam očekivala da je i tu kolegica Anja negdje, ali ne vidim, pa zato...
Anji se pohvalio auto, ona će doći kroz 40 minuta, pa će pridružiti, naravno.
Zato sam rekla Riječani, pa se ispričavam, jer nisam vidjela Anju, dobro.
Ne, doći će na putu, samo je morala ići autobusom, tako da će malo se produži njen dolazak. Što se tiče trenutno nam je u kvaru aparat koji je poslan na popravak, međutim taj trenutni popravak traje već preko 1,5 godinu, ako ne čak i 2 godine, tako da za sada sa kateterima nemamo problema, jer zapravo uopće ne radimo više pH-metriju za 2 godine, tako da jednostavan je odgovor. Ali taj dio zapravo vodi naša glavna sestra endoskopije Katarina, tako da taj financijski dio na svu sreću mene toliko nisam upućen u to, tako da ne mogu baš odgovoriti, ali vjerujem da isto, ako ne i gore, kod vas u Zagrebu.
Da. Pa evo onda ću ja malo se preorijentirati na doktoricu Anu Močić-Pavić iz Klinike za dječje bolesti. Pa Ana, ako bi mi mogli reći neke indikacije u dječjoj dobi, zapravo kad postavljamo i na koji način se uopće orijentiramo kod djece za postavljanje pH katetera? Meni se...
Čujete me?
Čujemo. Malo je sporija slika, ali mislim da će ići.
Jel me čujete? Čujemo. Dobro.
Čujemo.
Hvala vam na pozivu i lijep pozdrav svima. Čujete, sa uvođenjem zapravo impedancijskog katetera više okrenuli prema njemu iz razloga zbog toga što naše indikacije što se tiče provođenja pH-metrije sa impedancom su više orijentirane na djecu sa neurološkim poremećajima i djecu sa respiratornim simptomima, kod kojih se u 50% slučajeva ne radi o refluksnim kiselim epizodama i zbog toga nam je ta konvencionalna pH-metrija nije bila dovoljno specifična. I onda smo se zapravo u posljednjih 5-6 godina zapravo dominantno orijentirali na impedancijske katetere. Danas nama je zapravo pH-metrija sa impedancom jedna od prvih pretraga koje radimo kod djece kod sumnje na postojanje refluksa i posebno u dječjoj dobi negdje do 10. godine, kada se još uvijek ne možemo ponašati prema njima kao prema odrasloj populaciji, skloni smo zapravo ipak napraviti prvo dijagnostiku prije bilo uvođenja kakve terapije. Ona nam je bitna da bi zapravo uopće mogli izdiferencirati tu neerozivnu refluksnu bolest ili hipersenzitivni jednjak ili funkcijske žgaravice s kojima se mi u zadnje vrijeme jako puno susrećemo. Tako da, što se toga tiče, nekako smo u današnje vrijeme skloni izvođenju impedancije nego same pH-metrije, usprkos toj cijeni, ali opet ne mogu reći da mi to u tolikoj mjeri možda radimo u odrasloj dobi kao i vi, tako da što se te financijske strane tiče, nekako smo opet malo, ajde reći, olakšani s tim. To je u prosjeku sada da radimo jedanput do 2 puta tjedno. I to su zapravo pretraga koja se provodi u bolnici. Mi naše aparate ne dajemo da pacijenti nose kući, jer ipak zbog specifičnosti pedijatrijske populacije i mogućnosti baratanja sa samim aparatom, tako da smo ipak skloni da djeca budu tu kod nas pod našim nadzorom. Nama bude problem zbog toga što gotovo 50% slučajeva se ne detektiraju ti simptomi, zapravo ne navode se zapravo kako bi se zapravo i trebala pratiti sama pretraga. A ono što je nama veliki problem u pedijatrijskoj populaciji što mi nemamo pravih referentnih vrijednosti prema kojima bi zapravo to mogli dobro protumačiti. Većina je zapravo naših referentnih vrijednosti ekstrapolacija iz dobivenih mjera kod djece kod koji se radilo iz određenog razloga impedanca, a onda kad se uvidjelo da nemaju zapravo određenih promjena, se nekako to svrstavalo onda u nekakve normalne referentne vrijednosti i naravno da se te vrijednosti mijenjaju sa dobom. Tako da kod dojenčadi puno smo više slobodniji u interpretaciji same impedance nego što je to onda prema odraslijoj dječjoj dobi koja je više tada sklona zapravo vrijednostima kao što susrećemo i kod odrasle populacije.
A koja je najranija dob zapravo koju vi postavljate? Aha, pardon, oprostite, profesor.
Ako mogu samo pitati,
mi vam radimo već i kod novorođenčadi.
Dobro, evo profesor Babić.
Mi vam radimo već i kod dojenčadi, zato što često...
Evo, Ana, ako možete dovršiti pa će profesor pitati.
Mislim, to što ste rekla, rana dob, zato što mi često imamo zapravo jedne recidirajuće apneje koje često budu sumnja na refluks, pa upravo iz tog razloga da neuropedijatrima olakšamo, nije nam problem ni tad i u najmanjoj dobi kod novorođenčadi od 4 tjedna izvesti pH-metriju sa impedancom. Tako da to je praktički pretraga koju radimo od rane dojenačke dobi.
Evo, profesor.
Da, dakle vi se možete jedino zapravo orijentirati na ono što vam uređaj pokaže. Kod te djece očito nema suradnje, zapisa dnevnika, stiskanja onih gumbića gdje se šta događa. Dakle morate se isključivo orijentirati na nalaz koji dobijete snimanjem.
Tako je. I dobro pregleda, da.
Da, jasno. A recite da li
sve te zapravo epizode koje su detektirane, da se vidi da li su zapravo to bile posljedice.
Da li još uvijek kod sumnje na hipersenzitivnost bronhalnu kod tih ljudi, kod te djece, da li ikada koristite još scintigrafiju pluća odgođenu drugi dan? Sa tehnicikoloidom ili tako nešto?
Evo, kako 10 godina su Klajčevo, ne.
Da.
Prvenstveno zbog samog postupka zračenja kod takve djece.
Da, jasno.
Štetnosti. Da.
Ja ne vidim, jel profesor...
Koliko ne, ali ne mogu reći...
Slobodno, Ana, slobodno. Ne vidim lice zamrznuto pa slušamo.
A meni su sve vaša zamrznuta, ali ne znam razlog zbog čega. Ali sebi sam pomična.
U svakom slučaju živi smo, ali evo, dišemo, ali slobodno recite do kraja. Da.
Pa zapravo i je najveći problem nama zapravo ekstraezofagealnih simptoma povezanosti sa refluksom. Danas je veliki taj prijepor između teških oblika alergijskih astme i koliko zapravo sam refluks doprinosi tome. Ali, kažem, impedanca je puno doprinijela tome upravo zbog toga što nam pokaže dokud zapravo sam taj reflukstat, koja je njegova proksimalna granica i da li je to sad zapravo ovisno o pH-u samog sadržaja, do koje mjere može utjecati i dovesti i do pojave respiratornih simptoma, jer nama zapravo djecu i često upućuju otorinolaringolozi gdje vide zapravo sumnju na laringofaringealni refluks i kao takve ih nam šalju, čak i stomatolozi sa erozijama cakline, gdje stvarno ne mogu reći da bude krivo upućeno dijete, jer smo imali puno puta slučaje gdje dijete doslovno nema simptome, ali erozija cakline bude takva da stvarno se pokaže patološki kiseli refluks.
Da, hvala. Je profesor Jurčić možda ovdje ili nije? Nije. Dobro, ako bi mogla samo zamoliti Tomislava, a tu ste profesore, da i vas pitamo nešto, sad vas vidimo. Pa evo, pričali smo o kateterima, pa na koji način zapravo Sveti Duh isto pristupa postavljanju katetera, kad odlučiti se za samo pH senzore. Ono što je meni veliko pitanje, evo profesor Sifrim, a vidjela sam da to u Londonu rade sa kateterima koji imaju i želučani pH i pH jednjaka mjere i impedance. Mi imamo samo ovaj koji ima distalni senzor u jednjaku. Pa zapravo ne znam koliko je, vjerojatno je velika prednost tog katetera, ali ne znam koliko on cjenovnom rangu. Što vi mislite o tom kateteru koji ima i želučani senzor? Bi li ga se isplatilo postavljati podredovno?
Bi.
Slabo vas čujemo, profesor Jurčić. Ako možete, Tomislav, ili vi pojačati?
Treba uključiti mikrofon, gospodin.
Dobro.
Evo ga, on je, sad se čujemo.
Čujemo se.
Čujemo se, jel? Čekaj sad. Jel se vidimo? Ja svoju sliku ne vidim.
Mi vas čujemo. Dobro, da.
Se vidimo?
Vidimo.
Bog, ovako, ta priča, idealno bi bilo normalno dvokanalni pH, čak vidjeli smo na onim, i postoji trokanalni pH plus sa impedancama kateteri, ali ta priča je jako skupa. I tu, ne znam, taj dvokanalni pH kateter je, ne znam, 3-4 puta skuplji u odnosu na sa jednokanalni sa impedancom. Zato tu treba, recimo, na neki način odmjeriti cost benefit i vidjeti što zapravo ono što je zanimljiva ta priča. Mi se uvijek moramo pitati što mi zaista pacijentu dobijemo, onaj edit value, kak bi rekli, što dobijemo sa dotičnom pretragom. Što mi to jako lijepo opišemo kad je gore zrak otišao, kad je tekućina, ovo ono, ali što nam je zapravo krajnji cilj, kako to utječe na našu terapijsku odluku. Za sada mi zapravo koristimo ove pH sa jednokanalne katetere sa impedancom, čisto iz tih razloga financijskih, jer teško dolazimo zapravo do sredstava novaca, mada svi podržavaju nas, ali kad treba izdvojiti za katetere, onda to teško ide. Tako da to je ta priča u tom smislu.
Da, evo sad je, hvala vam. Evo Tomislav je stavio ovaj lionski konsenzus kojega se dotaknuo profesor Sifrim, koji je zapravo bio dio te grupacije koja je zapravo donijela konsenzus. Evo čisto sam ga stavila u nadi da ću se ja ponovno posvijestiti koje su te neke brojke koje su mi potrebne da bi nešto proglasila normalnim, nešto patološkim. Ono s čim se mi zapravo u dnevnoj praksi, moji mlađi kolege i Maša i Mislav i ja uvijek pitamo, recimo ova siva zona između 4, znači znamo da je normalna ekspozicija distalnog jednjaka kiselini ako je manje od 4% ukupnog vremena. Znači nas često muči ova brojka između 4 i 6. Čemu se vi konkretno, profesor Jurčić, kad dobite takav nalaz, recimo da je 5, jel tu prevagne onda klinička slika ili prevagne anamneza?
Klinički njuh, ja bih rekao, pazi. Sve te smjernice i to je sve jako lijepo, ali treba na konkretnom slučaju to sve odvagnuti. Mi smo čuli te razne priče, a svjedoci smo i uspješnosti raznih tih terapijskih mogućnosti. Pa pošaljete takvog pacijenta kod psihologa, psihijatra, behavioral terapiju, ovo, ono, i na koncu vam se opet vrati. Bez nekog velikog, ja moram priznati ruku na srce, nisam vidio nekakvog velikog učinka i uspjeha u takvom liječenju. Znači, to je isto jedno područje. Mi to sve lijepo opisujemo, znamo sve, ali zapravo slabo možemo nešto napraviti. U nekim slučajevima čak ćete se odlučiti za kirurgiju, osobito kad je onakva hernija i to sve, kad čovjek ima... Evo, recimo pitanje, ja sam danas imao u ambulanti pacijenta, mlađi dečko koji ima nekakve bolove koji ga muče, pate pod dolje u epigastriji, pod lijevim i rebernim lukom, nikakvih refluksnih smetnji nema, ovo je sve znači, u redu i pH metrija, ali de facto on ima bolove koje su vjerojatno posljedica te klizne hiatus hernije koja mu stvara problem. Znači, evo, konkretno, kad gledate te smjernice, njega ne možete baš uklopiti ni u jednu smjernicu. Da li je za njega kirurgija, antirefluksna kirurgija, možda čak i je, ne znam, ali od druge strane, pošaljete tako čovjeka na kirurgiju, vrati on se sa sličnim, možda još gorim smetnjima, onda ste još u većem problemu. Znači, čitav niz je tu problema i nije situacija tako zapravo čista, jasna, i od pacijenta do pacijenta treba se pozabaviti. Normalno imati sve ovo, svu ovu priču sa ovim konsenzusima koji su lijepo napisani, to sve iskreirani, i onda se vratiti ovdje i odabrati, ne pretjerano maltretirati pacijenta, što je broj 1, jer ako mu ne pomogneš, a izmaltretiraš ga sa prevelikim pretragama, primjenom, ne znam, inhibitora protonske pumpe u nekim herojskim dozama, ovo sve skupa, pa čak vidjeli smo, pošalješ ga na kirurgiju, a ne napraviš mu. Znači, treba slušati pacijenta po meni i onda napraviti nekakav najrazumniji, najracionalniji pristup.
Da, profesor Babić, vi isto tako, je li klinički njuh zapravo prije konsenzusa ili nam je konsenzus, evo, ograda koje se moramo držati, pa onda...
Pa, mislim, konsenzus je dobra smjernica u svakom slučaju, ali moramo prosuditi kod svakog bolesnika, slično, mislim, što i sudac radi. Imate zakon, imate preporuke, imate opće stavove, imate presedane, a sudac opet donijet će presudu na temelju svog nosa i nekih sitnih činjenica, tako i vi ovdje. Morate jednostavno prosuditi, vidjeti, nekad jedan sitni detalj mozaika vam kompletno preokrene cijelu situaciju. Tako da treba apsolutno kliniku poštivati, slušati pacijenta, držati se smjernica u svakom slučaju, ali smjernice su zato da ih se drži, ali se mora isto tako prilagođavati bolesniku. Ne može, nijedna smjernica nema osjetljivost 100%, točnost 100%, dakle nijedna metoda koja je unutra, dakle statistička greška postoji. Ako sam dosta dugo bio u toj statistici, čak izmišljao nekakve bodovne sustave i gluposti svojedobno, vidio sam zapravo da malom promjenom nekih stvari vi možete puno utjecati na statistiku, onda ste u čudu što sad. Znate, one ribice u Nemu, onom crtiću, kad su došle konačno želja ispunila se, došle su u more, onda su na kraju zadnje kadari, a kaj sad? Dakle, jednostavno morate se prilagoditi tom bolesniku i izvući maksimum od njega. Ako treba upotrijebiti endoskopiju za vrijeme zahvata, još jedan put razgovarati s njim. Apsolutno psihijatra, osim jedne profesorice na Rijeci, koliko sam upoznao na jednom skupu koji je Drago organizirao, to je mislim jedina osoba koja u Hrvatskoj radi s tim. Imali smo sastanak o smetnjama gutanja koje je profesor Saklajićeve Grujić organizirao. I na kraju od nekih 200 prisutnih logopeda, svi vrlo zainteresirani da sudjeluju u tim bolestima jednjaka i smetnjama gutanja, na kraju svi junaci nikom ponikoše, nigdje nikoga, i niko se nije htio s time baviti. A došlo je 2 ljudi iz Amsterdama koji su vrlo lijepo prikazivali određene vježbe, određene situacije, jedan je bio otorinolaringolog, jedan je bio logoped. Dakle, vrlo jednostavno su prikazivali situacije koje do poboljšanja dovode, čak i kod plegičnih ljudi, sa gutanjem, sa antirefluksnim vježbama. No, međutim, eto, kao što vidite, prošlo je već, to je bila 2000. godina, 20 godina je prošlo, ništa se nije pomaklo. Dakle, jednostavno moramo se prilagoditi situaciji, što Drago veli, od pacijenta do pacijenta, ali apsolutno poštivati algoritme. Naravno, oni tu jesu da se poštuju, ali nisu bezuvjetni, jer ako vam zdrav razum kaže da je nešto drugo, napravit ćete to drugo.
Upravo zato smo...
A koliko mi zapravo u našem... Pardon, molim?
Upravo smo i zbog toga napravili ovaj sastanak i bila je ideja naša na Rebru da potaknemo ovo i naravno pod sigurno kapom profesora Jurčića, dakle, koji vodi referalni centar za funkcijske bolesti. Moramo se sigurno češće sastati na ovu temu razgovarati, pa Agata, ja mislim da možemo dalje nastaviti.
Ako vi kažete, profesore, da pače. Može. Idemo s manometrijom. Evo sad će nam kolegica Maša zapravo prikazati.
Da se kateter uvodi kroz nos, izaziva se iritacija oka, kratka nelagoda u tijelu dok treba progutati ili samo sondu. To je više manje sve od nelagode. Ostatak testa se sastoji od toga da ćete malo mirovati kroz 3 minute i onda ćemo krenuti na test sa vodom. Daju se 10 uteja po 5 ml. Ono što je bitno je kad vam damo 5 ml vode, da i kažemo kad progutate 30 sekundi nakon toga više minuta. Dobro, sada, ja ću lagano krenuti. Smo dobro? Samo mirno. Progutate lagano. Uzmite čašu bliže ustima. Opustite ramena i radite sitne, male gutljajčiće. Još jedan, bravo, još polagano, ne morate više, udahnite i izdah. Dobro, ovo je normalna reakcija. Dobro. Udahnut, izdahnut. Možemo skidati tijela. Ovako možete legnuti na krevet. I idućih 3 minute nećemo razgovarati s vama. Nelagodu koju osjećate, znači normalna i prisutna. Ajde, dajte nam slobodno. Ajmo gutat. Možete tako, gospodine? Znači, opet 10 sekundi nemamo gutanja i onda nastavljamo. Ono što sad slijedi, vidjet ćete 5-6 gutanja napraviti jedan za drugi. Onako kao da se želite dobro napraviti. Ne morate. Dobro, okej. Još nećemo pričati s vama.
Evo ga. Zahvaljujem Maši našoj koja je napravila manometriju. Mašo, imaš možda nešto nama za reći što je možda najteže u izvođenju manometrije tehnički?
Pa, ponekad, posebno kod bolesnika sa ahalazijom, zna biti teško naprosto proći donji sfinkter. Tako da mi smo već nešto pričali, ali uglavnom to uspijemo. Mi nismo koristili do sada endoskopiju kako bi se pomogli. Mislim da je to zapravo zgodna ideja za odsad nadalje, kako bi bili možda više uspješni u postavljanju, znači u pozicioniranju katetera kod takvih pacijenata. Pacijenti obično kad im lijepo objasnimo od čega se sve sastoji pretraga i što točno mjerimo, jako lijepo surađuju s nama i pokušaju nam pomoći u postavljanju samog katetera.
Hvala. Ako je Jelena tu, molila bi Jelenu samo kratki osvrt na čišćenje katetera, katetera kojeg mi imamo kod manometrije.
Naš kateter je višekratni kao i svi, ja mislim, manometrijski kateteri. Čistimo ga naravno mehanički i potapamo ga u dezinficijens kroz od 5 do 15 minuta, zavisno o otopini. Jako je bitno paziti o kojoj otopini se radi, kako ne bi na našem kateteru izazvalo koroziju ili nemogućnost da se više daljnji kateter koristi. Jako pažljivo moramo i postavljati sam kateter jer na njemu se nalaze senzori, mogu se oštetiti. Ono što je isto također bitno je ta kalibracija samog katetera prije izvođenja pretrage koja se sastoji od toga da se kateter potopi kroz 2 do 5 minuta na sobnoj temperaturi, znači nekakvoj idealnoj varijanti temperature u 2 ml vode, tako znači da ne bude ni previše ni premalo te tekućine, da jednostavno senzori budu pokriveni. Sama kalibracija se vidi na ekranu i kad je kateter spreman, onda se pristupi samom postavljanju.
Evo, hvala Jelena. Možda bi sad prvo započela sa doktoricom Močić, evo sa istim pitanjem koji kod pH metrije. Ana, indikacije za manometriju kod djece, od koje dobi možemo, dakle moja nekakva znanja od prije su da se manometrija jednjaka s ovim kateterom kojeg mi imamo može djeci od 7 godina nadalje. Ispravite me ako je krivo i evo nešto malo edukacije o pedijatriji.
Da, što se tiče solidnih katetera, oni su ipak za stariju dob, nekako uzmemo tu 7. 8. godinu, nekakvu prijelaznu dob kad bi to moglo se tako funkcionirati kao i kod odraslih. Mi solidni kateter nemamo, ja sam solidni kateter vidjela samo u Londonu tijekom edukacije kod koji su oni radili kod svoje djece. Mi smo nabavili vodopropusni kateter, oni su mi savjetovali da ipak to bude prvo vodopropusni kateter, da se nekako suživimo s njim, pa onda ako bude mogućnosti da se pređe i na solidni. Moje iskustvo za sad u obavljanju manometrija jednjaka je oskudno, budući da su tek napravljeno njih nekoliko. Međutim, evo sljedeći tjedan mi stiže dijete iz Sarajeva, zamolilo su, to je 20 mjeseci staro dijete kod koje su postavili sumnju na ahalaziju i zapravo to su htjeli sad da se i evaluira manometrijski, budući da je to postavljena dijagnoza na radiološki i endoskopski prije bilo kakve daljnje terapijske intervencije. Ne znam sad koliko će to biti stvarno da je ahalazija, da li će to biti možda nekakva kongenitalna stenoza s obzirom na samu dob djeteta, ali evo, oni zapravo što sam ja vidjela, isto tako, to je rana dojenačka dob da su već mogli obaviti manometriju, naravno uvijek je pitanje interpretacije takvih nalaza zbog i brojnih artefakata koji se događaju. To moraju biti mali gutljaji i mora se paziti naravno i kod vodopropusnih katetera kod male djece da taj protok koji daje sama pumpa bude puno manji nego kod odrasle populacije zbog, ne daj Bože, zapravo intoksikacije vodom tijekom trajanja same cijele pretrage. To su, na primjer, neke stvari koje moramo svakako voditi na računa sad s tehničke strane. Mislim, može se pokušati, ono što je veoma jednostavnije je što zapravo postavljanje samog katetera kod takvog djeteta nekad zahtijeva i primjenu sedacije, tako da midazolam se pokazao siguran kao takav da se može iskoristiti, a da neće kasnije utjecati na samu interpretaciju nalaza.
Ana, mi u odrasloj dobi zapravo držimo se Chicago klasifikacije kod opisivanja samog nalaza. Je li ta Chicago klasifikacija u dječjoj dobi ima smisla ili se vi držite nekakvih drugih preporuka?
Pa u principu trudi se zapravo implementirati Chicago klasifikacija i u pedijatrijsku populaciju, međutim postoje značajne odstupanja s kojima mi moramo voditi računa, prvenstveno zbog toga što je dužina jednjaka u pedijatrijskoj populaciji naravno ovisi o dobi. Kako dijete raste, tako će se sam jednjak povećavati, tako da vidjelo se zapravo da pojedini parametri kao što je integrirani relaksacijski tlak i što su DCI i DL, to su svi parametri koji su nam jako bitni u samom izračunu, međutim kod djece su oni puno odstupaju od odrasle populacije i upravo zbog tog moramo voditi računa jer oni su nešto veći, odnosno kraći u pedijatrijskoj populaciji, to su pokazale pojedine studije, prvenstveno Britanci i Australci najviše zapravo ispituju i rade, jer to nam može dovesti do predijagnosticiranja pojedinih poremećaja iz kategorije 2 i 3 što se tiče Chicago klasifikacije na uštrb možda kategorije 4. Tako da svakako moramo uzeti u obzir kojem pacijentu radimo, koje dobi, kakav je jednjak i da onda na taj način iskorigiramo IRP, DCI i DL ovisno o samoj dobi, ali međutim nemamo nekih drugih parametara s kojima se možemo voditi. Tako da Chicago klasifikacija se nastoji implementirati u pedijatrijsku populaciju. Ono zbog čega se manometrija jednjaka danas najviše radi kod djece, baš taj razlog primarni poremećaj motiliteta jednjaka, obrada zapravo disfagije, odinofagije ili nekardiogene boli kod djeteta, prije samih odluka za kirurški zahvat, kod fundoplikacija preporuka je. Danas se sve više govori i o poremećaju motiliteta kod djece sa eozinofilnim ezofagitisom kojeg mi sve više vidimo u posljednjih nekoliko godina i još, mislim, ne toliko često u pedijatrijskoj populaciji, ali i kod poremećaja vezivnog tkiva, bolesti vezano za vezivno tkivo, svakako dolazi indikacija da se obradi iz te strane jednja.
Lijepo, hvala. Profesor Babić, ako vam mogu postaviti pitanje, vi ste vjerojatno radili konvencionalnu manometriju, pa koliko je zapravo ova high resolution manometrija, koliko ste se preporodili radivši nju, je li smo dobili stvarno toliko veliku prednost što se tiče vremena osjećaja bolesnika da ga se ne maltretira previše, ako možete evo nam podijeliti neko vaše iskustvo ranije i usporedba sa današnjom.
Da, radio sam na starom uređaju nekada, a od kad je došla ova visokorezolucijska MMS-ova, to je nešto stvarno sasvim drugo. Ja sam tamo morao izračunavati visine, kuteve, dakle to je bilo poprilično mučno zaraditi. Dakle, onaj ispis koji dobijete, on vam daje nekakve osnovne parametre, ali vi ste morali izračunavati kuteve i amplitude, visine, vidjeti je li to standardizirana vrijednost. Dakle, ono prvo što sam radio kad sam počeo uopće raditi, to je bila dinamička scintigrafija jednjaka koju sam zapravo spojio dvije metode, dinamiku jednjaka sa scintigrafijom kod refluksa. Onda se iz toga kad su došle ove manometrije, a isti problem je bio gore i na Svetom Duhu, još dok sam i bio, to profesor Jurčić je više tada na tom uređaju bio, dakle on je, kako je ostao gore, dakle i oni su dobili novi aparat, ali u svakom slučaju ta visokorezolucijska manometrija, ona kako može koristiti Chicago klasifikaciju, zapravo sugerira vam već neke stvari. Izračune dobijete gotove. Isto kao kod ovih novih uređaja za pH-metriju gdje ste primali ukupan broj refluksnih perioda, imali ste koliko je vrijednost ispod pH-4, najduži period i u koje doba dana se to, odnosno vrijeme kad se to dogodilo. A sada ipak, dakle, od sve ove opreme vi možete puno bolje razlikovati, možete razlikovati i ahalazije, on vam pokazuje i smetnje izlaska iz jednjaka, ahalaziju, dakle puno dijagnostičkih parametra koje su prema onim vrijednostima što Chicago klasifikacija nudi moguće. Jasno da opet je potrebna, ono što smo i malo prije kod pH-metrije govorili, potrebna je i procjena samoga kliničara, jer kad se znaju nekakve apsurdne vrijednosti javiti, uređaj sam sugerira koje od mjernih vrijednosti nakon tih 10 gutljaja, koje vrijednosti nisu za analizu. No, međutim, nekad baš se te vrijednosti uklapaju u analizu. Pa ako je uređaj to objavio da ne bi bilo prihvatljivo, treba dobro razmisliti zapravo da li to stvarno nije prihvatljiva vrijednost. Neka od tih, ja uvijek zbog toga radim i rezervne gutljaje. Dakle, nikad idem na 10 gutljaja, idem na 12-13 gutljaja. jer uvijek se može desiti kod patologije jednjaka da vam računalo sugerira da nešto nije uzeo u obzir. Bolje imati 10 gutljaja, naravno, čistih, ali baš zbog toga da bi ih dobio, ali nekad sam zadovoljan i sa 7-8 gutljaja. Ako mi 6-7 gutljaja izbaci iz nekog razloga, onda vidim da li neki od tih gutljaja mogu uzeti u obzir i onda to uzmem u obzir. I ono što recimo vam je zanimljivo vidjeti da li su apsurdne računice, vrlo jednostavna metoda. Dakle, uzmite ono što vam računalo sugerira. Nakon toga uzmite u obzir i ono što računalo nije uzelo u obzir i označite onu zadnju kućicu za analizu. I vidjet ćete da li postoje bilo kakva odstupanja. Ako vam računalo je pokazalo da su neki od događaja nesuvisli, a ne uklapa se u ostalo, dakle on bi ipak bio za uzeti u obzir. Međutim, ako vam svi događaji kada ih uzmete pokažu se neupotrebljivima, onda uzmete ove koji, dakle ipak je neka greška bila. Ali može se desiti da jedan događaj bitno mijenja situaciju, onda taj događaj idete analizirati i vidjeti je li on stvarno promijenio, usporedite s klinikom ili ne. Evo, to je princip po kojem radim. Dakle, najlakše je stisnuti enter, dobiti Chicago klasifikaciju, uzeti ono što je jasno, ali vrlo često to traje puno duže, čak i nego ono što, kako se ja zafrkavam, nego što nam HZZO prizna u minute našega rada, koliko ta pretraga vrijedi. Dakle, nekad treba stvarno se potruditi oko svega toga.
Da, mislim da taj humani faktor je zapravo vrlo bitan, da ne smijemo samo robotu prepustiti da izračuna i definira pacijenta. Ono s čim se mi znamo nekad zapravo mučiti u analizi je ovaj test slobodnog pijenja ili multiple drinking test. Znači, nekad ako izvodite kod svojih pacijenata da vidite kolika je peristaltička rezerva. Znači, imate li iskustvo kako bi analizirali, često vidimo onaj postkontrakcijski gutljaj koji je uredan, međutim nema adekvatne inhibicije ovih gutljeva prije. I tu se uvijek dvojimo, znači imamo kompletno uredan nalaz, ali nam se doima da peristaltička rezerva nije baš očuvana. Ja se nekak tu vodim isto s tim kliničkim svojim pristupom, odnosno njuhom, pa onda uzmem u obzir kompletnu anamnezu i ne želim proglasiti pacijenta patologijom ako mi je sve do tada bilo uredno. Kako vi zapravo prema tom se postavite?
Ista stvar, procjenjujem od bolesnika do bolesnika. Da. Od bolesnika do bolesnika procjenjujem tu peristaltičku rezervu. Evo jedan primjer sad koji se nedavno desio, mladi čovjek koji čak i dijelo medicinske struke, dakle on je forsirao da ne može trpiti simptome, bilo mu je jasno rečeno da je taj distalni DCI da je dosta slab i pitanje da li će se popraviti, otišao je na stavljanje balona dakle oko jednjaka kako bi se povećao tlak. Desilo se ono što sam i predvidio, da sadržaj više ne može prolaziti kroz jednjak. Sad je pitanje, nakon 23.000 eura plaćenih u Beču, da li taj balon vaditi van i što s njim napraviti. Evo. Dakle, to su stvari gdje se slušalo robota. Jer naravno kad je došao u privatnu ustanovu gdje je to je dobro, je kod njih je DCI bio dobar, ne znam kako su ga dobili dobroga, meni to stvarno nije jasno. To je neki David Copperfield doslovno moram reći radio, jer ako je on bio 50, onda naravno jasno je da ne može biti u referentnim vrijednostima da se smije bilo kakva korekcija tlakova distalnog jednjaka raditi, ili klasična, ili laparoskopska, ili stavljanje balona, dakle sve je jasno. Ali eto.
Da.
Sad se reći, dakle, apsolutno klinička procjena i vidjeti na čemu jesmo. I uvijek vrlo oprezno kod procjene svake. Rađe ponoviti nakon nekog vremena terapije pa vidjeti odgovor na terapiju kakav je, ako vam se nešto čini od toga, ajde idemo ciljano to liječiti, vidjeti kakav je odgovor, pa onda konačno donijeti. A uvijek napisati nalaz vrlo vjerojatno suspektno, treba procjena i tako.
Da, hvala. Kolega Licul, kolika je zapravo potreba za manometrijama u Rijeci? Ako možete neki mali osvrt, vaša perspektiva manometrija.
Pa ovako, lijep pozdrav ponovo svima. Znači, ono što je važno naglasiti, mi smo počeli s ovim se baviti, i ja i kolegica Radovan i ja, unazad jednu godinu i par mjeseci, nakon edukacije naše. Za sada otprilike se polako kolegama i digestivcima, znači digestivnim kirurzima i kolege naše sa odjela Zavoda za gastroenterologije, polako se privikavaju da to mi počinjemo raditi, tako da otprilike do ove sada faze sa koronom, što se malo izmijenjala nam situaciju, otprilike prosječno smo imali otprilike 1 do 2 pacijenta za gornju manometriju tjedno. To se nam dosta smanjilo, otprilike sada samo zapravo dosta više indikacije se rade zbog posebne epidemiološke stanja i malo nedostatka osoblja, tako da otprilike imamo jedno otprilike 3-4 pacijenta mjesečno. Najčešće uzrok rađenja je ahalazija, a onda neke teže gastroezofagne refluksne tegobe, hijatalne hernije, nam kolege šalju digestivci za koje nije jasno nakon gastroskopije i pasaže nije znači to su otprilike najčešće indikacije za sada za gornju kod nas. Kažemo otprilike sada jedna tjedno, jedna u 10 dana se kod nas izvodi.
Dobro, vjerojatno će biti i više postepidemijski, jel da?
Da, bit će puno više, ne samo toga, nego i svega, općenito svih pacijenata, tako i ovoga. Dosta pacijenata i mi sami, oni odjavljuju, nije im trenutno da dolaze, moraju imati naravno test na COVID negativan, tako da je to sve postalo malo, ne samo za gornju manometriju, nego i za gornju endoskopiju. Recimo, evo, kod nas se desilo zadnjih 10 dana, uopće nemamo listu čekanja za gornju endoskopiju, ljudi zapravo uopće otkazuju, tako da i za ovo jednostavno ljudi počinju tu nekakvu obradu koja im nije toliko smetnjene predstavlja, zapravo su je odgodili, sigurno već jedno za pol godine.
Da, hvala. Evo vidim, dobili smo jedno pitanje iz publike, zapravo virtualne publike, pa možda profesora Jurčića da pitam, znači možemo li komentirati...
Samo ako bi se mogao ja malo uključiti da ne zaboravim ovdje, sve skupa jurcamo. Recimo, evo kad je nadovezao bi se na ovo pitanje vaše za ova konvencionalna i high resolution manometrija. Mislim, ruku na srce, high resolution manometrija je manometrija u bojicama ovako lijepim, a ja se često vratim na onu linijsku ili već kako ćemo, kad hoću vidjeti nešto, još analizirati malo podrobnije i moram priznati da mi ona možda čak neke podatke da ovako bolje nego ovo izgubnice u tim cijelim bojama. Kod nas vidio su svi ovi postupnici, Chicago 1, 2, 3, ne znam šta sve za rekao, analno i tako, London, ono, ali znači da mi ne smijemo sad glorificirati, zna se high resolution manometrija je zapravo možda najveći doprinos u dijagnosticiranju ahalazije ili ovoga tipa 3 ahalazije i tako, ali gledajući ovo ili recimo taj procenat tih hijatalnih, ali mi smo to, ja sam nekad radio 6-kanalnu, tu smo radili, imali onaj grifona aparat i to je sasvim lijepe si mogao naći, možda lakše ćeš se orijentirati sa manje kanalnom tom manometrijom nego sa ovakvim silnim zapisima. Dobro, ajde, ruku na srce, ne znam, ako treba. Evo sad smo ti solid state kateteri. Solid state kateteri su isto lijepa priča. Navodno se negdje sad rani normalno da ovaj zapadni svijet, ali i taj zapadni svijet ne radi, svi ne rade sve sa solid state kateterima. To je negdje oko 50% pretraga prema nekim mojim informacijama sad kad sam razgovarao s ovima kad smo bili tamo u Nizozemskoj. A sad vidite recimo taj solid state kateter kod nas košta 220.000 kuna, da, 220.000 kuna date za jedan solid kateter. Vi na Reboru imate gore samo solid state kateter.
Samo solid state, baš sam vas to i mislila pitati s obzirom da vi imate i silikonske, te rezultate kako su komparabilni vaši ispiti.
Dobro. Znači, solid state kateter, koliko vam traje otprilike solid state kateter?
Tu je Jelen, ali nama je trajao otprilike 3 do 4 godine. To je sad, prebačili smo 500 procedura, da, jer smo ga relativno dobro pazili.
Da, to ste dobro. Mi imamo, ja imam, onda sam ga čuvao ko oči u glavi i onda smo mi strunili su mi oni mjehurići tamo, jeli? Pa onda sam ga poslao pa se nikad nije vratio. Druga stvar, kad sam kod solid state katetera, znači ove ljude iz MMS-a sam pitao tamo izravno i zapravo tu u jednom razgovoru pa je bilo rečeno da koštaju ti solid state kateteri 10.000 eura. Sad, to nije pitanje, dobro, ajde, ali je pitanje za sve nas. Kak sad kod nas može koštati takav jedan kateter 220.000 kuna, ako je 10.000 kuna, ako me ovo konvertiranje ne vara, to je negdje 70.000, 10.000 eura je 70.000 kuna, 75 ili već kao koliki je tečaj, ali znači, i sad, ja sam se stresao kad sam vidio, znači to je 3 puta skuplje. To najprije tu, recimo tu mi nije jasno, ali vi ne možete niti doći. Imate samo jednog dobavljača tih solid state katetera, znači ni do te priče, znači to. Sa vodom perfudiranim kateterima mi to radimo, istina nastavimo normalno, jer je elegancija, to ti je živa elegancija, užitak radi sa solid state kateterom. Gurneš tamo, čačkaš zubi, izmjeriš to što si planirao i idemo dalje. Jel? I zaista to je veliko poboljšanje ovako gledajući. Što se tiče kvalitete i usporedbe, normalno da ne možeš uspoređivati, tu postoji nekakve sitne razlike, ali je taj vodom perfudirani kateter daje sasvim dobre rezultate, reproducibilne i tako dalje, već kako pouzdane, ali ono što kod njega morate paziti da se svako malo desi da se neki otvor od tih, ne znam koliko, 32, 36 povremeno se zaštopa, pa treba to otkloniti, treba i mehanika. Tako da s te strane je to ta priča. Znači, anorektalno isto tako radimo sa solid stateom i to je zaista se dobro pokazalo. Znači, ta priča sa vodom perfundiranim, jedan vodom perfundirani kateter košta negdje par tisuća kuna. I možeš ga koristiti zaista jako puno, isto normalno pravilno održavanje i tako dalje. Znači, kad mi gledamo sad nekakvu, recimo, cost benefit, recimo analizu i tako dalje, onda je to neusporedivo. A ne dobiješ puno na nekakvoj ekstra kvaliteti, ne dobiješ puno temeljnih kliničkih informacija koje bi te uputili kardinalno za tog svog pacijenta što bi mu doprinijeli u nekom posjeterapijskom smislu, u odnosu na ovaj.
Koliko je pacijentima zapravo ugodnije s ovim silikonskim, odnosno vodom perfundiranim kateterima? Je li im ipak ugodnije postavljanje nego čvrsti kateter, solid state?
Ne. Zapravo ovdje mi imamo tu taktiku da čim počneš uvoditi kateter, da pacijent zapravo polagano radi gutlja. Neki ljudi to podnesu, većina ih podnese bez ikakvih problema, ali ne vidim neku razliku između jednih i drugih u tom uvođenju. Tako da, tako mi znamo, ali daleko je normalno, elegantnije raditi, jednostavnije sa solid state kateterom.
Da, mislim da zapravo proizvođač, bar nam su tak rekli, 200-tinjak procedura da bi trebao izdržati solid state. Mi smo ga uspjeli premašiti tu brojku, ali svejedno, evo, cjenovno je dosta zahtjevno. Da, profesor Babić, vi isto radite sa solid state-om?
Protočnim kateterima radim zbog cijene. Dakle, protočni kateter, točna cijena je 55.000 kuna, 36 kanalni za jednjak i 24 kanalni za rektum sa balonom je nešto par tisuća kuna jeftiniji. No, međutim, taj balon se može zamijeniti.
Žarko, oprosti, koliko ste rekao cijenu?
55.000 kuna, to je ono što smo platili.
Pa neko te debelo, za jedan kateter?
Za jedan kateter, a višekratni protočni kateter za jednjak 36 kanalni 55.000 kuna otprilike. Ali oni kažu 50 pacijenata. Samo što smo mi napravili preko 300 pacijenata s jednim kateterom.
Pa to je nešto neštino. U nabavi ti nešto neštino. Pa mi imamo, svaki dan imamo račune to. Evo vidiš, to je zanimljivo.
Evo vaš račun, vidim koliko je.
Benchmarking, evo, to se zove benchmarking, evo vidiš, to je zanimljivo.
Ali taj kateter izdrži, velim, oni garantiraju 50 bolesnika, mi smo komotno napravili uvijek je baždaren, uvijek je bilo sve u redu, dakle preko 300 bolesnika smo napravili s jednim kateterom, s drugim oko 200 i nešto, dakle isplativ je, jeftiniji je i rezultati su sasvim zadovoljavajući, puno toga se može dobiti s njim.
Da, zapravo je skrb o kateteru je zapravo skoro toliko važna koliko i skrb o pacijentu. Kad znamo kolika je cijena u igri.
Da, imam sestru koja to fantastično radi, koja toliko brine o tim kateterima, tako da, velim, taj jedan kateter koji smo čudili smo se, ono idemo dalje, dobar je. I skoro 350 ljudi smo s jednim kateterom napravili, što je bilo, kad smo rekli predstavniku MMS-a, čudio se, ma nije moguće, a moguće je.
Sve je moguće, da.
Da, moguće.
A profesor Babić, s obzirom da vi radite i antroduodenalnu manometriju, to je isto čvrsti kateter ili kako?
Ne, to je protočni kateter sa manjim brojem odvoda, imate 12 i 24 odvoda na njemu, dakle to su kateteri koji su jednaki kao ovi, samo što je manji broj odvoda, zbog toga ne možete visokorezolucijsku, ne možete kolor dobiti, ne možete visokorezolucijsku manometriju, ali ono što vam može, da vam računalo detektira motoričke migracijske komplekse, dakle on to znači bojom. I onda možete vidjeti nešto slično kao kod manometrije kad gledate refluks, dakle smjer kretanja u kojem val ide, da li se prenosi, morate označiti mjesto. Kad ulazite unutra, postavite ga. Dakle, vidite koliko ste duboko ušli gastroskopom ili enteroskopom čak. Na vrh katetera ima rupa jedna gdje je kirurški konac stavljen. I taj kirurški konac pričvrstite klipsom na određeno mjesto. Pazite kod izvlačenja, vidite da se nije što pomaknulo. Napravite u mirovanju, napravite nakon toga, nakon obroga, mora biti 2 kilokalorije po mililitru. Dakle, nekakav Ensure plus Advance ili nekakav Fresubin tih karakteristika. To proguta, čeka se opet pola sata i nakon toga se daju određeni prokinetici koji djeluju na kalcijske kanale, na dopaminske receptore i tako dalje. Dakle, sve ono što dajemo kao neostigmin i tako dalje, dakle sve što dajemo na određeni segment što djeluje. Po ovome mjerenju nakon uzimanja hrane vidite da li on javlja kakve tegobe, dakle vidite i taj senzorički defekt da li postoji nekakav, jer zna se da je distenzija antruma puno veća kod dispepsije, kod određenih poremećaja. I mjerenja traju nekada 3 sata, nekad 5 sati, ovisi koliko izdrži i na svu sreću obično ta klipsa na kraju otpadne kad uđemo endoskopom da to izvadimo van. Međutim, desi vam se incident da vam između onih klješća za rezanje konac, to je vodoresorptivni konac, dakle se zaglavi pa imate muku sa odvajanjem jer kateter kroz nos, endoskop je kroz usta i onda ste u čudu, kad to je obično najbolje doći do želuca i onda unutra to manipulirati, probati to riješiti ili koristiti endoskop sa dva radna kanala, što isto znam koristiti vrlo često kod takvih ljudi, jer onda ako mi što zaglavi sa jednim, onda uđem drugim škarama i razrežem tu cijelu situaciju. Dok kod kolona isti je postupak, isto se radi i isti broj kanala ima, samo je kateter nešto malo drugačije modificiran i sa onim svojim čipovima je prijavljen kao kolon kateter. Dakle, ima software za to koji je posebno kupljen za antroduodenum i tanko crijevo i za kolon. Protočni kateteri postoji, to je ono što mi je MMS mogao ponuditi. To su imali.
Žarko, samo komentirati, ti radiš ovu stacionarnu antroduodenojejunalnu manometriju, jel? Stacionarno.
Da.
Znači, to traje koliko? Pola sata, sat vremena, 2 sata?
A ne, traje.
Pacijent leži na stolu i radiš manometriju.
Da, pacijent leži na stolu, gledaj, kad se uvede kateter i fiksira, mora 30 minuta barem biti pacijent na miru da se peristaltička aktivnost smiri. Onda dobije obrok, onda se nakon 30 minuta ide sa određenim medikamentom terapijom. Dakle, i onda se čeka opet koliko taj djeluje, ne znam, recimo pinaveribromid treba barem 30 do 40 minuta da bi djelovao. Onda radiš snimanje 20 minuta. Dakle, to se zna od 3 do 5 sati protegnuti snimanje.
Znači, mi smo nabavili svojevremeno, imamo portable, odnosno uređaj, znači za dinamičku antroduodenojejunalnu manometriju, negdje, istina, to je bilo oko 6 ili odvoda, takvi 8 maksimum zapravo. Onda nam se taj kateter probušio, isto tako nismo ga uspjeli popraviti. Napravili smo možda koju na antroduodenojejunalnu manometriju, jer nju ima smisla raditi samo na duži vremenski period, recimo onda dobiješ objektivniji rezultat i to. A druga stvar, uvođenja toga katetera isto to može biti intervencije, pa moraš intervenirati endoskopom i to da prođe taj kateter, tako da je procedura je komplicirana. Ali ono, pozicioniraš prema motoričkom modelu, motilitetu, otprilike prepoznaš ovaj antronni dio i ovaj i tako je.
Da, i to, može i tako.
Ali
da, može i tako, velim.
Da.
Uvedem ga uz pomoć endoskopa, fiksiram i onda sam siguran da je na svojem mjestu u određeno vrijeme koliko pacijent leži na stolu. A krenem obično oko 9 ujutro i to završi negdje do 2, 3, pola 4 popodne. Mučna procedura, invazivna, ali nekad je vrlo korisna stvarno.
Mogli bi se krenuti sa zaključcima. Možemo.
Ja bi se samo dotaknula, imali smo jedno pitanje koliko vidim u chatu, ali mislim da je to pitanje postavljeno profesoru Sifrimu, s obzirom da je komentar kardiogastričnog refluksa i posljedica na vagus, pa ću se ja potruditi proslijediti pitanje i dati objektivan i razuman odgovor kolegici, evo ga. Ja se zapravo u svoje ime... Recite, profesore.
Imao sam i to. Nedavno sam sa našim docentom Hadžibegovićem rješavao, paralelno smo radili Holter EKG sa impedansa pehametrijom. I riješili smo pacijenta.
Bravo, super.
Je.
Bitna je volja, a onda se može naći...
Nismo publicirali, ali planiramo publicirati to kao ovako jedan realitet.
Evo,
Izvrsno. Ja se zahvaljujem svim sudionicima okruglog stola i nadam se da je ovo bilo poticajno i da reaktiviramo, dakle, u svim centrima našim, poglavito sveučilišnim, manometriju, dakle funkcionalne testove u gastroenterologiji i da u biti pokušamo i sa HZZO-om razgovarati, jer zbilja to cijene su vrlo bitne i moramo ih unificirati. Evo, zahvaljujem se svima, a mi bi krenuli dalje sa našim workshopom i radionicom. Naime, ja bih napravio on with our presentations. Ako imate, možete staviti sada kratki blok.
To enhance the visibility of suspicious areas, which is especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI is supporting better visibility of potential lesions, resulting in image details at a level that typically only very experienced endoscopists have learned to see. TXI aims to contribute to lower miss rates for inflammation and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of TXI is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce TXI as the new white light. Edop provides a continuously sharp image at any point in the endoscopic workflow. Edop stands for Extended Depth of Field. The incoming beam of light is divided by the beam splitter and reflected via two mirrors to the sensor. This technology projects two images with identical content that, however, exhibit different focal lengths and combines those images into one image in total focus. Edop supports the detection of lesions through improved visibility, thanks to a broad focus range and less blurring. Edop allows for a much closer distance to the object in normal mode compared to previous dual-focus endoscopes. Therefore, Edop was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. Edop is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, it allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. Observations, NBI enhances the visibility of superficial vessels. NBI stands for narrow band imaging. In contrast to the previous series, EVIS X1, NBI uses LED illumination. Blue and green light penetrate only the superficial layers of the tissue. If a superficial blood vessel is present, blue and green light are both strongly absorbed. The vessel appears darker and is therefore more visible. If the deeper penetrating green light hits a vessel that is out of the reach of the blue light, only the green light is strongly absorbed. The deeper vessel appears in cyan, in contrast to the superficial vessel. NBI is the most validated and society-endorsed imaging modality for optical assessment of lesions. It supports high diagnostic accuracy and high confidence in diagnostic decisions, and it has internationally validated classification schemes in place. Designed to enhance the visibility of deep vessels and bleeding points during endoscopic treatment. RDI stands for red dichromatic imaging. RDI uses an additional amber LED. Red light penetrates deeper into the tissue compared to green light. If a deep blood vessel is present, amber light is strongly absorbed. The vessel appears darker and is therefore more visible. If the amber light hits a bleeding point at which the blood concentration is very high, the amber light is strongly absorbed. The bleeding point appears darker and is therefore more visible. RDI thus helps to efficiently identify the bleeding source during endoscopic resections. This supports clinicians to coagulate bleeding vessels quicker and easier. Therefore, RDI helps to reduce stress and procedure time for treatment of emergency bleedings and endoscopic resections. RDI aims to help to avoid delayed bleeding after EMR or ESD. RDI may improve speed, efficiency, and safety of endoscopic treatment.
Here we are again. And we are coming to the last part of our morning session, and this is it's my honor to present the winners of the endoscopic section of Croatian Society of Gastroenterology Scholarship, and for the best proposal plan for multicentric prospective study for young gastroenterologists. And we have two winners, and they will present now their proposals. Now, they split the winning prize of €1,000, and I think that will be something that will give them wings for future work. So I will announce the Dr. Vibor Šeša, and he will make his plan for clinical applicability of gastroscopy with narrowband imaging for detection, severity, staging of H. pylori gastritis.
Okay. Thank you, Professor. So, hi everyone, my name is Vibor Šeša. I'm gastroenterology resident at University Hospital Center of Zagreb, and in the next few slides I will present our proposal study with the title of Clinical Usage of NBI Imaging for Detection and Severity Staging of Helicobacter pylori gastritis. So, next slide, please. So, this is an area of ongoing interest because of the well-known reasons. So far, the endoscopic finding with the best correlation with histologic finding is the presence of regular arrangement of collecting granules, which are usually seen in the normal gastric corpus of Helicobacter negative status, which has a negative predictor value for Helicobacter infections about 90%. On the other hand, mucosal swelling and redness without these changes are observed in Helicobacter pylori infected mucosa. NBI offers further investigation and staging of severity of Helicobacter pylori gastritis in terms of detection of gastric atrophy and intestinal metaplasia. Next slide, please. So the aim of this study is to test NBI endoscopy in detection of Helicobacter pylori infection and severity staging and comparing it to our histologic findings. Next slide, please. So it will be, as the professor said, a multicentric and prospective study. After a standard high-resolution white light examination and taking pictures of gastric corpus, antrum, and incisura, we will continue our examination with NBI imaging, comparing it to the white light examination, and then we will take biopsy specimens according to Sydney protocol. So two biopsies from antrum, corpus, and two from incisura. Reference standard, as I said, will be histology. Okay, next slide. So before endoscopy, we will set 5 types of endoscopic findings according to gastric appearance on white light endoscopy and narrowband imaging. So now I will present these 5 types. Next slide, please. So first type will be normal gastric mucosa without Helicobacter pylori infections, where we can see a presence of regular arrangement of collecting granules. On the left side is white light endoscopy, and on the right side is narrowband imaging endoscopy. Next slide, please. Here we can see a presence of cone-shaped gastric fleas, which is usually highly suggestive of mild Helicobacter pylori gastritis positive patients. Next, please. Third type is mucosa with these rod-shaped gastric pits and a cleft-like mucosa, which is associated with moderate severe gastritis. Next, please. Fourth type will be the presence of ground glass-like mucosa, which is highly suggestive for gastric atrophy. And the last one, and type 5, will be finding of dark brown patches with bluish margin and irregular border, which is highly suggestive of intestinal metaplasia. So our plan is to compare these 5 types of endoscopic findings with histologic results, and then after that present our results. So far, the most studies are retrospective, and there is no prospective study of this type in European population. So that's all. Thanks. Okay. Okay, hello. Hello, everybody. I'm Radovan Prič, and I will present our research proposal. And the title is Digital Assistant Development for Appropriate Referral for Colonoscopy. So to speak, chatbot assistant. Next slide. So in this research proposal, there will be 3 gastroenterology centers involved, as you can see on this slide. Our hospital and Clinical Hospital Holy Spirit and University Hospital Center Sisters of Mercy, are all in Zagreb. Next slide, please. Okay, today we see increasing requirements for colonoscopy. That is partially because of our national program for early prevention of colorectal cancer. On the other hand, there is also ongoing need for adequate assessment of risks and benefits for this invasive diagnostic procedure. Next slide. In this context, there is also increased demand and pressure on public health system. And also, we need to consider increasing the risk of unsuitability of certain indications for this procedure. We observe in the recent years emergence of application of different artificial intelligence methods in gastrointestinal endoscopy. One of these systems is also chatbot systems, which are primarily used for talking to patients, transmitting information, promoting health and education. Next slide. So, our proposal is to develop the digital assistant for physician support in appropriate referral for colonoscopy. And this artificial intelligence-based system will be based on European panel of the appropriateness of gastrointestinal endoscopy criteria for appropriate indications for colonoscopy. Next slide. And our primary objective is to develop this digital assistant. And it will be designed to assist primary care physicians and also gastroenterologists in deciding on the appropriateness for different indications for colonoscopy. Also, our secondary objectives will be, after the chatbot is created and used, to make a validation in clinical practice by comparing the recommended indications for colonoscopy from the artificial intelligence system with diagnostic outcomes in practice, and also to compare the suitability of these indications for colonoscopy observed by chatbot assistant with different indications by other physicians which will not use the application. Next slide. So this is our project proposal. Thank you very much for your attention.
Okay, we are finishing our morning session, and I must say that we have for these proposals, and we have international jury with Klaus Monkemiller from Germany, Bojan Tepeš from Slovenia, Ivan Jovanović from Serbia, Rusmir Mesihović from Bosnia and Herzegovina, and from Croatia, Hrvoje Iveković and myself. So we divided and split the winning prize on these two prosperous young endoscopists, and this proposal is for the young endoscopists up to 40 years old. So now we will continue. We will continue with our workshop, and we will go now for the Model A, education and training on the ex vivo porcine models, and after that for the Model C, we will go in veterinarian faculty in their operation rooms, and we will practice poem and other related endoscopic therapeutic procedures for the Model C. And as a closing remark, I can say that we try to raise the awareness of the functional diseases regarding the diagnostics and also therapy. So thank you very much for joining us on this session in these rough weathers, rough times, weathers. Thank you very much, and greetings from Croatia, and thank you very much for all participants that we have in our for our lectures and our members of the round table. Thank you very much, and bye from Zagreb. Okay. See you in operation room.
To enhance the visibility of suspicious areas, which is especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI is supporting better visibility of potential lesions, resulting in image details at a level that typically only very experienced endoscopists have learned to see. TXI aims to contribute to lower miss rates for inflammation and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of TXI is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce TXI as the new white light. Edop provides a continuously sharp image at any point in the endoscopic workflow. Edop stands for Extended Depth of Field. The incoming beam of light is divided by the beam splitter and reflected via two mirrors to the sensor. This technology projects two images with identical content that, however, exhibit different focal lengths and combines those images into one image in total focus. Edop supports the detection of lesions through improved visibility, thanks to a broad focus range and less blurring. Edop allows for a much closer distance to the object in normal mode compared to previous dual-focus endoscopes. Therefore, Edop was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. Edop is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, it allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. Observations, NBI enhances the visibility of superficial vessels. NBI stands for narrow band imaging. In contrast to the previous series, EVIS X1, NBI uses LED illumination. Blue and green light penetrate only the superficial layers of the tissue. If a superficial blood vessel is present, blue and green light are both strongly absorbed. The vessel appears darker and is therefore more visible. If the deeper penetrating green light hits a vessel that is out of the reach of the blue light, only the green light is strongly absorbed. The deeper vessel appears in cyan, in contrast to the superficial vessel. NBI is the most validated and society-endorsed imaging modality for optical assessment of lesions. It supports high diagnostic accuracy and high confidence in diagnostic decisions, and it has internationally validated classification schemes in place. Designed to enhance the visibility of deep vessels and bleeding points during endoscopic treatment. RDI stands for red dichromatic imaging. RDI uses an additional amber LED. Red light penetrates deeper into the tissue compared to green light. If a deep blood vessel is present, amber light is strongly absorbed. The vessel appears darker and is therefore more visible. If the amber light hits a bleeding point at which the blood concentration is very high, the amber light is strongly absorbed. The bleeding point appears darker and is therefore more visible. RDI thus helps to efficiently identify the bleeding source during endoscopic resections. This supports clinicians to coagulate bleeding vessels quicker and easier. Therefore, RDI helps to reduce stress and procedure time for treatment of emergency bleedings and endoscopic resections. RDI aims to help to avoid delayed bleeding after EMR or ESD. RDI may improve speed, efficiency, and safety of endoscopic treatment. Especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI is supporting better visibility of potential lesions, resulting in image details at a level that typically only very experienced endoscopists have learned to see. TXI aims to contribute to lower miss rates for inflammation and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of TXI is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce TXI as the new white light. continuously sharp image at any point in the endoscopic workflow. Edop stands for extended depth of field. The incoming beam of light is divided by the beam splitter and reflected via two mirrors to the sensor. This technology projects two images with identical content that, however, exhibit different focal lengths and combines those images into one image in total focus. Edop supports the detection of lesions through improved visibility thanks to a broad focus range and less blurring. Edop allows for a much closer distance to the object in normal mode compared to previous dual-focus endoscopes. Therefore, Edop was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. Edop is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, it allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. Observations, NBI enhances the visibility of superficial vessels. NBI stands for narrow band imaging. In contrast to the previous series, EVIS X1, NBI uses LED illumination. Blue and green light penetrate only the superficial layers of the tissue. If a superficial blood vessel is present, blue and green light are both strongly absorbed. The vessel appears darker and is therefore more visible. If the deeper penetrating green light hits a vessel that is out of the reach of the blue light, only the green light is strongly absorbed. The deeper vessel appears in cyan, in contrast to the superficial vessel. NBI is the most validated and society-endorsed imaging modality for optical assessment of lesions. It supports high diagnostic accuracy and high confidence in diagnostic decisions, and it has internationally validated classification schemes in place. To enhance the visibility of deep vessels and bleeding points during endoscopic treatment. RDI stands for red dichromatic imaging. RDI uses an additional amber LED. Red light penetrates deeper into the tissue compared to green light. If a deep blood vessel is present, amber light is strongly absorbed. The vessel appears darker and is therefore more visible. If the amber light hits a bleeding point at which the blood concentration is very high, the amber light is strongly absorbed. The bleeding point appears darker and is therefore more visible. RDI thus helps to efficiently identify the bleeding source during endoscopic resections. This supports clinicians to coagulate bleeding vessels quicker and easier. Therefore, RDI helps to reduce stress and procedure time for treatment of emergency bleedings and endoscopic resections. RDI aims to help to avoid delayed bleeding after EMR or ESD. RDI may improve speed, efficiency, and safety of endoscopic treatment. To enhance the visibility of suspicious areas, which is especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI is supporting better visibility of potential lesions, resulting in image details at a level that typically only very experienced endoscopists have learned to see. TXI aims to contribute to lower miss rates for inflammation and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of TXI is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce TXI as the new white light. Edop provides a continuously sharp image at any point in the endoscopic workflow. Edop stands for Extended Depth of Field. The incoming beam of light is divided by the beam splitter and reflected via two mirrors to the sensor. This technology projects two images with identical content that, however, exhibit different focal lengths and combines those images into one image in total focus. Edop supports the detection of lesions through improved visibility, thanks to a broad focus range and less blurring. Edop allows for a much closer distance to the object in normal mode compared to previous dual-focus endoscopes. Therefore, Edop was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. Edop is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, it allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. Observations, NBI enhances the visibility of superficial vessels. NBI stands for Narrow Band Imaging. In contrast to the previous series, EVIS X1, NBI uses LED illumination. Blue and green light penetrate only the superficial layers of the tissue. If a superficial blood vessel is present, blue and green light are both strongly absorbed. The vessel appears darker and is therefore more visible. If the deeper penetrating green light hits a vessel that is out of the reach of the blue light, only the green light is strongly absorbed. The deeper vessel appears in cyan, in contrast to the superficial vessel. NBI is the most validated and society-endorsed imaging modality for optical assessment of lesions. It supports high diagnostic accuracy and high confidence in diagnostic decisions, and it has internationally validated classification schemes in place. RDI is designed to enhance the visibility of deep vessels and bleeding points during endoscopic treatment. RDI stands for red dichromatic imaging. RDI uses an additional amber LED. Red light penetrates deeper into the tissue compared to green light. If a deep blood vessel is present, amber light is strongly absorbed. The vessel appears darker and is therefore more visible. If the amber light hits a bleeding point at which the blood concentration is very high, the amber light is strongly absorbed. The bleeding point appears darker and is therefore more visible. RDI thus helps to efficiently identify the bleeding source during endoscopic resections. This supports clinicians to coagulate bleeding vessels quicker and easier. Therefore, RDI helps to reduce stress and procedure time for treatment of emergency bleedings and endoscopic resections. RDI aims to help to avoid delayed bleeding after EMR or ESD. RDI may improve speed, efficiency, and safety of endoscopic treatment. Especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI is supporting better visibility of potential lesions, resulting in image details at a level that typically only very experienced endoscopists have learned to see. TXI aims to contribute to lower miss rates for inflammation and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of TXI is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce TXI as the new white light. Edop provides a continuously sharp image at any point in the endoscopic workflow. Edop stands for Extended Depth of Field. The incoming beam of light is divided by the beam splitter and reflected via two mirrors to the sensor. This technology projects two images with identical content that, however, exhibit different focal lengths and combines those images into one image in total focus. Edop supports the detection of lesions through improved visibility, thanks to a broad focus range and less blurring. Edop allows for a much closer distance to the object in normal mode compared to previous dual-focus endoscopes. Therefore, Edop was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. Edop is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, It allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. NBI enhances the visibility of superficial vessels. NBI stands for narrow band imaging. In contrast to the previous series, EVIS X1, NBI uses LED illumination. Blue and green light penetrate only the superficial layers of the tissue. If a superficial blood vessel is present, blue and green light are both strongly absorbed. The vessel appears darker and is therefore more visible. If the deeper penetrating green light hits a vessel that is out of the reach of the blue light, only the green light is strongly absorbed. The deeper vessel appears in cyan, in contrast to the superficial vessel. NBI is the most validated and society-endorsed imaging modality for optical assessment of lesions. It supports high diagnostic accuracy and high confidence in diagnostic decisions, and it has internationally validated classification schemes in place. RDI stands for red dichromatic imaging. RDI uses an additional amber LED. Red light penetrates deeper into the tissue compared to green light. If a deep blood vessel is present, amber light is strongly absorbed. The vessel appears darker and is therefore more visible. If the amber light hits a bleeding point at which the blood concentration is very high, the amber light is strongly absorbed. The bleeding point appears darker and is therefore more visible. RDI thus helps to efficiently identify the bleeding source during endoscopic resections. This supports clinicians to coagulate bleeding vessels quicker and easier. Therefore, RDI helps to reduce stress and procedure time for treatment of emergency bleedings and endoscopic resections. RDI aims to help to avoid delayed bleeding after EMR or ESD. RDI may improve speed, efficiency, and safety of endoscopic treatment. Especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. Txi is supporting better visibility of potential lesions, resulting in image details at a level that typically only very experienced endoscopists have learned to see. Txi aims to contribute to lower miss rates for inflammation and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of Txi is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce Txi as the new white light. Edop provides a continuously sharp image at any point in the endoscopic workflow. Edop stands for Extended Depth of Field. The incoming beam of light is divided by the beam splitter and reflected via two mirrors to the sensor. This technology projects two images with identical content that, however, exhibit different focal lengths and combines those images into one image in total focus. Edop supports the detection of lesions through improved visibility, thanks to a broad focus range and less blurring. Edop allows for a much closer distance to the object in normal mode compared to previous dual-focus endoscopes. Therefore, Edop was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. Edop is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, it allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. Observations, NBI enhances the visibility of superficial vessels. NBI stands for narrow band imaging. In contrast to the previous series, EVIS X1, NBI uses LED illumination. Blue and green light penetrate only the superficial layers of the tissue. If a superficial blood vessel is present, blue and green light are both strongly absorbed. The vessel appears darker and is therefore more visible. If the deeper penetrating green light hits a vessel that is out of the reach of the blue light, only the green light is strongly absorbed. The deeper vessel appears in cyan, in contrast to the superficial vessel. NBI is the most validated and society-endorsed imaging modality for optical assessment of lesions. It supports high diagnostic accuracy and high confidence in diagnostic decisions, and it has internationally validated classification schemes in place. Of deep vessels and bleeding points during endoscopic treatment. RDI stands for red dichromatic imaging. RDI uses an additional amber LED. Red light penetrates deeper into the tissue compared to green light. If a deep blood vessel is present, amber light is strongly absorbed. The vessel appears darker and is therefore more visible. If the amber light hits a bleeding point at which the blood concentration is very high, the amber light is strongly absorbed. The bleeding point appears darker and is therefore more visible. RDI thus helps to efficiently identify the bleeding source during endoscopic resections. This supports clinicians to coagulate bleeding vessels quicker and easier. Therefore, RDI helps to reduce stress and procedure time for treatment of emergency bleedings and endoscopic resections. RDI aims to help to avoid delayed bleeding after EMR or ESD. RDI may improve speed, efficiency, and safety of endoscopic treatment.